A very good morning, dear colleagues, friends, and delegates who have registered for this webinar on breast diseases. Ruby Hall Clinic has organized this webinar, especially on the occasion of International Women's Day. And actually, breast diseases specialty is a very nascent specialty. It has come up in the last 5 to 10 years. And a lot of research has been done on breast diseases, and a lot of advancements have been made. We are, of course, still in the process of improving the patient care and getting better diagnostics and better treatment modalities. However, this field really needs detailed discussions and interactions amongst colleagues who've been practicing this and other fields also. We are working in close relationships with our general practitioners, with gynecologists, with general surgeons. And to enhance that collaboration, we have organized this meeting so that the exact and correct information about breast diseases can be disseminated, and we can all work together to improve the care of patients with breast diseases. So again, a very warm welcome to all of you. And I would like to start the meeting by inviting Dr. Varsha Hardas. Dr. Varsha Hardas is a very senior consultant radiologist working in Ruby Hall Clinic. She's the head of the breast imaging department, and she's finished her MD radiology in 1991 from Pune University. She's a national and international speaker at multiple conferences, and her main area of interest is breast imaging. She's been the ex-governing council member of Breast Imaging Society of India, advisory and current executive committee member of IRIA Pune chapter, and she's very actively involved in the treatment and diagnostics of patients with breast diseases, especially breast cancer. She has conducted a lot of CMEs and conferences and is very actively proponing this field. She's been a DNB teacher also since 2005. We are very fortunate to have Dr. Varsha here with us today to share her knowledge with us. Please welcome Dr. Varsha Hardas. Please come, ma'am.
Hi, a very, very good morning to everyone. Sunday morning, talking about breast diseases. I'm very happy that all of you have logged in, and it's a field which I think not many of us are very well versed with, and but we have to know that breast cancer is really very, very common these days. In fact, it is one of the leading cancers in women. When we are talking about breast cancer, it starts with breast imaging. Now we know that mammography has been the main, sorry, there is some problem here. Okay, so we know that mammography has been the main investigation of choice, but there has been a lot of advances in imaging as far as concerned. So today I'm just going to talk about the advances, and they are tomosynthesis, contrast enhanced mammography, MRI, and vacuum assisted biopsy. All of us know that the days of analog screen film mammography and computed mammography are really gone by. Now is the era of 3D tomosynthesis, a 3D mammogram. So we know that how the 2D mammograms used to look and how the sensitivity of these 2D mammograms were very, very low, especially because there was a lot of tissue superimpositions, and all these images could hide big cancers. They could make normal tissue look like pathology. And even if we could see the lesions, the morphological details were obscured, and it was very difficult for acute characterization. And just to show an example that how large cancers like this were hidden on a mammogram, which was a 2D mammogram, a screen film, or a computed radiography images. So we moved ahead. There was technical advance of full field digital mammography, where there was a direct conversion of the images at the level of digital detector, which produced really very sharp, high contrast images. And these high contrast images were seen on high resolution monitors. Also, with the advent of digital technology, the patient dose was reduced. The discomfort caused by the compression during a mammogram was also reduced almost up to 50%. And that is one of the main things that initially, when it was only CR mammography and 2D mammography, patients used to really scare away from doing their mammograms because they thought it was a very painful procedures, but it is no more the same now. Of course, with digital advent, the time taken for the study is much more reduced. We don't need to take extra projections, because we can really manipulate all these images on these high resolution electronic monitors. So to understand the basic of tomosynthesis, we will just see that the conventional 2D imaging, normally what happens is the incident X-rays are just going straight like this. So if there's a lesion sitting here and the parenchyma is below this, these two tissues are going to get superimposed, and that is what is going to cause either hiding of the cancers or limitations to detect those lesions. But what happens in tomosynthesis acquisition is that these exposures from the machine are taken from different angles. So different angles will cause separation of this lesion from the normal superimposing breast parenchyma. To understand, this is the new machine that we have, a tomosynthesis machine. So during the acquisition, this machine is going to make an arc over the breast and take at least 9 projections. Our machine has an angle, sweep angle of 25 degrees. It takes 9 projection, and the scan time is also not too much. It is just 9 seconds. So the compression time is also reduced, and it has taken multiple projections. Now, all these raw projections which we have acquired by the machine, there is a reconstruction of these images, and they are converted into thin 1 millimeter slices. And these thin 1 millimeter slices also produce a synthesized image, which is a 2D image. So this is all technology. It's not very difficult to understand. So what happens is that these all 1 millimeter images are displayed on the high resolution monitor, one by one. So you can either see them one by one by manual way, or you can see them in a cine loop fashion. So the image slices, what we are seeing are 1 millimeter thickness. That means the image is having the anatomical information only about 3 millimeter of tissue, which is lying up above it and below it. The rest of the tissue, the breast, is blurred out. So you can imagine that this 1 millimeter slice is going to give us very good image quality, high contrast image quality. It is going to help us pick up all small lesions and also give us a good morphological detailing. To understand this in a very simple way is that we all know about HRCT, the actual imaging that we do, high resolution CT cuts. And if we compare that with the 2D X-ray, we know that we get so much more information on these 3D high resolution imaging of the thorax. Likewise, same thing happens in a 3D mammogram. Whatever we see on a 2D mammogram is what we see on 3D is much more accurate, much more detailing is seen on these 1 millimeter slices. So with digital breast tomosynthesis, by and large, the problems of tissue overlaps are very significantly eliminated. And that's why it gives us a very high diagnostic accuracy, because it is giving us a lot of morphological details. And because of which we are able to detect small cancers. And that's why the cancer detection rates are also gone higher. And there have been multiple studies which have demonstrated and proved this, that with the help of digital breast tomosynthesis, we are definitely, the detection rate of cancer is much higher and much smaller cancers have been detected. So just to see the examples, now this is a lady who is a 61-year-old lady, has no clinical symptoms. She has come for routine screening mammogram because she's visiting her daughter. She has absolutely no positive family history regarding either CA breast or CA ovary. Now we are looking at her 2D mammogram picture. It's a very dense breast parenchyma for a 61-year-old lady. Now on our 2D mammogram, we really don't see much. Maybe there is a little suspicion of some lesion sitting over here, but of course the detailing is not so good. But when we look at her 3D mammogram, and this is one of her slices because this is a 1 millimeter slice, look at this beautiful image here. What is showing us is that definitely there is a speculated lesion sitting in her left breast in her quadrant, definitely suspicious for a malignant lesion. Not only that, there was a big lesion hiding in her breast tissue in another slice where we are able to see this, that there is something happening over here. We may not be able to give a definite diagnosis on this, but definitely there is a lesion sitting here as well. Her right breast was normal, there was nothing there, but this lesion definitely is very, very suspicious. So this is an era of multimodality imaging. We always will take these patients who have positive findings on mammogram. We will go ahead and do a ultrasound for them. And this ultrasound is showing that there is a hypoechoic irregular lesion sitting in her left breast at 8 o'clock position. And there is another lesion, which is this one here on ultrasound. Again, a very heterogeneously solid lesion, not a very simple cyst or a fibroadenoma, again, a very suspicious lesion. So with the help of 3D mammogram, we are able to pick up not one, but two lesions in an asymptomatic patient where clinically there was no finding. So we went ahead and did an image guided core biopsy because they were looking suspicious, and both these lesions turned out to be invasive ductal carcinomas. But because the lady was not very comfortable having a mastectomy, both these lesions were treated with breast conservative surgery, and it was only possible because of mammography, and we could localize these lesions on mammogram. We did a wire localization for both these lesions, and both these lesions were excised completely, and now she's on regular follow-up and doing extremely well and happy that she could save her breast. Yet another example, this is a 43-year-old lady who has been operated for the right side for CA breast in 2013, and she's coming for a routine surveillance. Now, this is her mammogram, a 2D mammogram, CC view and MLO view shows post-therapy changes in her right breast, and nothing very remarkable on her right side. This is a small involuted fibroadenoma, which was always present even in her previous mammograms. Now, when she came again, of course, she's been undergoing 3D tomosynthesis only, but this time on her 3D slice, we picked up a small lesion, which is sitting right here in her left breast. This is a contralateral breast, and this is her small fibroadenoma, but this lesion was new when we compared it with her old mammogram. There was nothing suspicious on our old mammogram in that area. You can see it very clearly. So if we compare from 2019, this is a new development in 2020, definitely suspicious. We have to do an ultrasound. This is called as targeted ultrasound. We do a targeted ultrasound for this lesion. And here we see a hypoechoic irregular solid lesion, definitely not looking like a benign lesion. We have picked up a very small non-palpable lesion in a patient who has undergone right-sided BCT for breast cancer, and now is having another lesion which is suspicious for a contralateral breast cancer. And of course, we did an image-guided core biopsy, which turned out to be an invasive ductal carcinoma, which was not palpable clinically, but only because of imaging, because of 3D, we could pick up this lesion very well before it was clinically evident. Now, the advantage of tomosynthesis is that the margin evaluation is extremely well. We have talked about it, but you see this is one case, this is the second case. Now, hardly we can see that there is a lesion here on a 2D mammogram. Likewise, maybe there is a small lesion that we are suspecting on a 2D mammogram here. But when we do a 3D tomosynthesis, what we realize is that there's a large lesion which was palpable, but was not evident on a 2D mammogram. But on a 3D mammogram, we can see that there is definitely a well encapsulated lesion with fat density. That means it is nothing but a benign lesion. It is a hamartoma. So tomosynthesis has helped us that a palpable lesion which is present in this lady is nothing but a benign hamartoma. Just leave it alone, let her go home. Likewise, in this particular case also, again, a lesion which was not showing very well, the margins were obscured on 2D, but very well seen on a 3D tomoslice, definitely looking very benign. We can let it go, and we can leave this patient alone and put her on surveillance. Another example for a lady who was 59-year-old, lump in the right breast developed just few months back, came for imaging. Her 3D mammogram is showing that there is a lobulated high density mass over here. Now, very benign appearing on 3D tomosynthesis because there are no associated calcifications, no skin thickening, no retraction, just a lump which is bilobed. But of course, we will not leave that at this point. We will always go ahead and do a mammogram, do an ultrasound for this lady. Though it appears benign on a mammogram, we will go ahead and do a high resolution ultrasound, which showed that this was not a simple cyst, but a complex cyst with low level internal echoes. And not only that, she also had a solid mural nodule, which was irregular and lobulated here and showing good amount of vascularity. Definitely the BIRATS 2 lesion now becomes BIRATS 4B, suspicious for an intracystic papillary lesion. It could be simple papilloma or tumor, but definitely it's not a simple cyst to be left alone. So imaging has told us that this lesion needs to be biopsied. We went ahead and did a biopsy, image-guided biopsy from the solid core, and this turned out to be an intracystic papillary tumor, and which was resected later and confirmed. So what we understand now is that 3D mammogram is the new standard. We cannot anymore rely on screen film mammography or CR mammography, but we must, if available, definitely take uh, help of this 3D mammogram, which will help us detect a lot of lesion, will help us characterize the lesions accurately, and which will help in treatment planning. And these are, I'm talking about small cancers, and also helping us to detect microcalcifications in a screening setup. So just to say the same thing, that detecting small non-palpable lesions, characterizing them very accurately. That means when I say accurately, that means if we say that this is a BIRATS 4 or a 5 lesion or a BIRATS 2 lesion, if a biopsy is done, it has a high positive predictive value. It means that will be, if a lesion is suspected to be a cancer, it definitely many times turns out to be cancer and not otherwise. So this is definitely enhancing the performance of imaging modality, and that in turn helps us for better treatment planning and patient care. So coming to the next advancement that has happened recently, because now 3D tomosynthesis is quite old, that has been there for many, many years. But the new thing that has come is contrast enhanced mammography. Now this happens in the same, with the same machine in the same room. So you don't require any other machine for this procedure. It's only a software upgrade because there is an additional of X-ray filter, which is a copper filter. That's the hardware upgrade. So a little bit of software upgrade, little bit of hardware upgrade. With the help of a power injector, we will just inject some contrast into the lady's vein. This is nothing but a standard non-iodized CT contrast that we are using at the rate of 1.5 cc per kg body weight. And this is injected with the help of a pressure injector at the rate of 3 cc per second. And a saline flush is done that. Now, the interesting part is that when the contrast has been injected, the patient is lying down. The patient is not in a position for a mammogram. She can very comfortably be lying down, and then the procedure of acquiring the mammographic images starts after 2 minutes after the injection. And it can be done in the same mammographic room with the same machine. So what is the technology behind it? Once we have injected the contrast injection, the machine will make dual energy exposures in rapid sequence. That means we are going to take the standard CCN MLO view that we take for normal mammography, the same way the images are taken, but the machine is going to take dual energy imaging. It's going to take a low kV and high kV imaging. At the same time, the compression time is also the same, it's not increased. And immediately after taking the exposures, after we have taken 4 exposures, the machine is only going to do the subtraction of 2D images, and we are going to achieve this contrast image. This is a subtraction post-contrast image. Now you can imagine this is the lady for whom we are doing this contrast enhanced mammography. Look at her breast. It is so dense. Even on a 3D mammogram, we were hardly able to see anything, but she did have a palpable nodularity. But when you do a contrast enhanced mammography, what we see is beautifully the cancer has been highlighted with the contrast. And not only that, but there are 2 small satellite nodules also that we have seen, and the rest of the breast is normal, and her opposite breast was also normal. So with this technology, we have been able to really pick up that hiding cancer in a very dense breast parenchyma with the help of contrast enhanced mammography. This is another example of a 57-year-old lady who had a clinically palpable nodule in her upper quadrant. USG showed a suspicious nodule, was not very confirming about the nature of the lesion. Now, when contrast enhanced mammography was done, what we are seeing is not one, but multiple foci of enhancing lesions. That means this is a multifocal cancer disease that is present in her breast. And on core biopsy, it turned out to be IDC with DIS. So contrast enhanced mammography is very easy, and it is very easy and gives us a very fast interpretation. As soon as the procedure is end, the images are transferred to the monitor, and we can really interpret it right there and there. The surgeons can come and have a look at the mammogram, the contrast enhanced mammography. It is very easy to correlate these images with the normal mammography images. Very easy for the surgeons to understand. It is a very viable and a very cheap alternative to MRI. And whenever there are patients where MRI is contraindicated, I think this is a very ideal technique to evaluate the patients where MRI was indicated but is not possible. So we call this as contrast enhanced mammography as a poor man's MRI. So this is available in India as well. Now, talking very briefly about MRI, of course, it's a very important and a problem solving tool in whereas as far as breast imaging is concerned. Anytime when there is a problem with the conventional imaging where mammography and ultrasound has failed to give us a diagnosis, MRI really comes to our rescue. But doing an MRI with a 3D imaging 3D machine with a dedicated breast coil is what is very important. To do it on 1.5 or a lesser MRI machines without a breast coil, it is going to give us a lot of problems. It will give us wrong answers. So it is avoidable to do the MRI on those machines. And also, it is important to understand that we cannot do MRI for each and every patient. The indications for MRI breast for a patient is limited. We can only do them in cases where we have detected a cancer and we do not know the extent of the lesion properly on conventional imaging, but the patient wants to undergo a breast conservative surgery. I think that is an ideal situation. Also, when we are evaluating post-contrast, post-NACT resolution of the tumor, MRI is a good way to evaluate the residual disease. Whenever patients have had lumpectomy with positive margins, in those patients, also MRI is very useful because of the surgery, the conventional imaging has limitation for interpretation because of the scar tissue, the seromas, the hematomas. So in that cases, the MRI is going to be very, very helpful to detect small residual disease, especially with positive, where patients have positive margins. Also, MRI is very, very helpful in detecting any integrity of the saline implants. So there are limitations, there are limited uh, indications for doing an MRI. We cannot do a MRI for a patient who walks in and says, okay, I want to do an MRI. that is going to create a lot of problems and give a false negatives and false positives. So it is definitely avoidable. Just to show a few examples, the MRI will very beautifully show us any residual disease or multifocal disease. It's also very helpful in evaluating the implants and the integrity of implants. If there is rupture of the implant, MRI is very, very sensitive. And this is the only time when in MR breast, we are not going to use contrast. We are going to do non-contrast MR imaging. Just to show the example in this patient, where this was a lactating lady, and you can imagine her breasts were very, very dense, and she came up with a palpable lump, and ultrasound and mammography had showed just a single lesion. When we had biopsied, it turned out to be cancer, pregnancy related cancer. But when we did an MR for this patient, you can see that the extent of disease was huge. It was not only multicentric, but it was a multifocal and multicentric disease which was present and covering almost her entire of her right breast. Just to, yeah, okay. So I move ahead. So coming next to vacuum assisted biopsy, this is a new thing. Please give me 5 minutes. I'm going to just show you this new technology that we have, where there is this VAB machine, which is, it is called a VAB machine, which has vacuum assisted biopsy needle, and see how the needle core, it opens up and cuts the tissue and then sucks the tissue into this chamber over here. Now, with the help of this needle and this machine, which is vacuum assisted, we can do a lot of biopsies, and not only biopsies, but we can also resect benign lesions. And especially very helpful where clinically the lesions are not palpable, and we want to biopsy the calcifications, which we do with the help of stereotactic biopsy, with the help of stereotactic machine. This is a very new technology, and we have this available with us, and we have used it to not only biopsy calcifications, but also resect some small fibroadenomas, and it does beautifully. So just to show an example, this is a lady, 42-year-old with strong positive family history, and has already detected a contralateral IDC and shows suspicious microcalcification in her other breast. Now, this is not palpable. There is no USG correlate. So the only way to biopsy this is with the help of stereotactic biopsy, with the help of VAB machine. And this turned out to be a high-grade DCI. So it is very important. It was very important for this patient, especially because she had a contralateral breast malignancy, which was clinically palpable. But if it was not, this particular one was not detected, she would have had undergone treatment only for her right side and not the left side. But because we detected this with the imaging, and also not only detected, but also helped them take a diagnosis with the help of VAB, the treatment planning definitely changed. And the surgeon was able to give her treatment for both the breasts at the same time. This is a small, young 23-year-old lady who had this painful benign lesion in her left breast for a very long time, and she was very uncomfortable. We just went ahead and did a vacuum assisted biopsy. You can see that completely the lesion has been resected with the help of the vacuum biopsy, which was a daycare procedure. Within 10 minutes, the lesion was out. There was a very small hematoma, and she's doing extremely well on follow-up now. So to conclude, there has been a lot of advancement in breast imaging, and that has definitely helped not only in detecting and diagnosing lesion, but also helped a lot in treatment planning for the surgeons. 3D tomosynthesis, contrast enhanced MRI, high resolution ultrasound, which we use very often to do image guided biopsies, have helped us to detect and diagnose early non-palpable breast cancers, and helped in treatment planning of the patient. Thank you very much for your listening, patient listening, and giving me extra minutes. Thank you very much.
Thank you very much, Dr. Varsha Hardas. That was a very exhaustive and beautifully explained discussion on breast imaging. It was quite simple to understand and gave us a lot of insights about how to investigate a patient with breast complaints. I have a question from a delegate. What are the advantages of 3D mammography over simple conventional mammography?
I think I've already mentioned that in my lecture that 3D mammogram is giving us, helping us to avoid the tissue overlap. And when it helps to avoid the tissue overlap in a breast, which is a 3D structure, which is an organ which is has a volume, and then it is compressed and only a 2D image is taken. There is a lot of tissue overlap. But with 3D, what happens is that we are seeing only 1 millimeter slices. That is giving us a lot of information at that level. So it helps us to detect small lesions. It helps us to characterize those lesions very well, because there's uh, very less tissue overlap. So it definitely helps us pick up cancers and characterize them. Either they are cancers or benign lesions, but it really helps us a lot. And the confidence of the radiologist to say that, okay, this is a benign lesion or this is a malignant lesion is very, very high. And as I said, the positive predictive value of those conclusions that we make out of 3D images is definitely very high. If we say it's a malignancy, many a time, more than 95% of times, it turns out to be a malignant lesion.
Okay, there's another question. Are contrast enhanced mammography and MRI interchangeable? Like, can you use either of them for the diseases?
Right. I think, yes, we can. That is what the whole aim is, because, we know that there is minimal availability of MRI. It's very, very expensive. Not all people can afford it. And also it requires a lot of expertise. I said it requires a 3D, 3T MRI with a dedicated breast coil. So not many places are equipped with these machines. In that case, it will become easy for us to do a contrast enhanced mammography, and it will give us equally good information as it gives on MRI. That is what the plan is, and that's why we call it as poor man's MRI. It gives us a very good information. It's very fast. It's much cheaper. It will be available soon uh, everywhere. Let's hope so.
Okay, thank you very much, ma'am. Now we'll move ahead with the session.
Sure. Thank you.
Thank you. So our next talk is going to be by Dr. Mansi Munshi. Dr. Mansi Munshi is a consultant radiation oncologist working at Ruby Hall Clinic, Pune. She's also specialized in cancer genetics. She's graduated from radiation oncology from Tata Memorial Hospital, Mumbai, with 2 gold medals and a rich clinical experience in both radiation oncology and cancer genetics. She's also the first person to start cancer genetic clinic at Ruby Hall in 2018. She has special interest in breast cancer, prostate, gynecological malignancies, and SBRT. I invite Dr. Mansi Munshi to please share her presentation with us, and I'm sure we'll have a very fruitful discussion after that. Dr. Mansi, please.
Good morning, Dr. Mani. Good morning to everybody. Thank you very much for having me today for this. It's always a pleasure to talk on this platform. And my topic for today is the management of hereditary and breast cancer management. So, right at the outset, I'd like to start with this, photo where we all know that breast cancer is now the number one cancer amongst women in India. It overtook cervical cancer a few years ago. And we know the famous statistic that 1 in 8 women will have breast cancer at some point in their life. And the first question which pops into the mind of a patient always is that, why did it happen? Why did it happen to me? And the answer to that is that there are multiple reasons. So it's usually a combination of lifestyle, carcinogens, which we're surrounded by, hormones, but genetics plays a huge role in all cancers and especially in breast cancer. Now, when we talk about mutations or genetics, it's basically two types of mutations. You have germline mutations and somatic mutations. Now, somatic mutations are those which are acquired after birth, so they don't get passed on from one generation to the other, and they're usually confined to the tumor tissue. So, for example, a tobacco chewer, chronic tobacco chewer, if he develops somatic mutations in the oral mucosa, then those mutations will be seen and there'll be a tumor forming in the oral mucosa. Whereas germline mutations are those which are present in sperms and eggs and then get passed on from one generation to another. They're present in all cells of the body and predisposed to certain types of cancers depending on which gene is involved. So in today's talk, the genes, the mutations which we'll be talking about are the germline mutations. Now, tumor suppressor genes, is a term which you must have all heard during training days. These are genes which are, they're present for everybody. They're good genes which prevent cancer from happening. Now, they work just like the brakes of a car to prevent an accident from happening. And if there is a mutation or a defect in these genes, then it leads to a higher chance of having cancer. Doesn't mean that the person will definitely get cancer, but it leads to a higher chance of getting cancer. And there's a word called penetrance, which you would come across when reading literature, which basically means that the chance of developing a cancer when you have a defective gene, like the chance of having an accident if your brakes are faulty. So a highly penetrant gene like a BRCA1 means that the person, if they carry a faulty gene, they would have a very high risk of having cancer in their lifetime. It's never 100%, but it would be close to 70-80%. And then there are low penetrant genes which do not give such a high risk. Now, autosomal dominant and autosomal recessive, I'm sure all of you are very familiar with these terms. Most of the genes which are related with HBOCS, that is hereditary breast ovarian cancer syndrome, are autosomal dominant, which means they get transmitted with a 50% chance from one generation to the other, and a single copy, a single mutated copy is enough to develop the phenotype or develop the syndrome. And most of the genes, even the BRCA1 and 2, are both autosomal dominant, whereas autosomal recessive are much less commonly seen in the clinic, and they pass on with 25% risk to each offspring. Now, when would you suspect to have that a patient sitting in front of you in the clinic has, hereditary breast ovarian cancer syndrome, or when should you offer genetic evaluation to such patients? So the answer is young age of onset, so young age for breast cancer, which is 45 years of age. Generally considered. If you have a patient with a triple negative breast cancer, then that age goes up to 60. So any patient below 60 with a triple negative breast cancer should be offered genetic evaluation. Bilateral breast cancer, which we see not so uncommonly. The NCCN guidelines say that every case of ovarian cancer should be offered genetic evaluation. So even a single standalone case. If a person has multiple family members, so a strong family history of clustering, but that has to be from the same side of the family, that is the same bloodline. And it's not necessary that the family history would be just breast cancer, ovarian cancer. You also have to ask for male cancers or other cancers like prostate, pancreas, colorectal cancers. So any history of cancer in the family is significant. A personal history of more than one cancer. So if a lady has had breast cancer, now has ovarian cancer or some other cancer, then we must think of this as well. And of course, if they have a relative, a blood relative who already has done the testing and has a known mutation, which is becoming more and more common. Now, all of this sounds quite theoretical, and some of it sounds that it may not be that important, but the cancer genetics, hereditary cancers, and the law are very closely related. And while doing research on this topic, I came across a number of very interesting lawsuits which had happened in Western countries. And I feel like this is becoming more and more relevant in the Indian scenario. And I just want to start off with this before we jump into some clinical situations. So this was a lawsuit in which a doctor did not inform the patient of breast cancer, that she also had a risk for ovarian cancer because of certain family histories and certain risk factors. And she later got ovarian cancer and sued the doctor for $5 million. So this was a case in which the doctor had failed to inform or had not informed about genetic evaluation. And on the other end of the spectrum, I found a case where over enthusiastically a genetic test was done. The test was wrongly interpreted by the doctor's team as a pathogenic mutation, and a prophylactic breast and surgery was done, and a hysterectomy was done. Later to find out that the mutation was a normal variation of VUS and not a pathogenic mutation. So this lady was 36, so that is quite a serious offense. So this is the other end of the spectrum where it was done, but it was wrongly interpreted. So I think the time has come for for everyone to be very, very sensitive about this issue. And let's jump into some clinical scenarios now. So the case that I've chosen to discuss is the most common case that we would see in the clinic. This is a 38-year-old lady with 2 children, premenopausal, no comorbidities, and she belongs to the Konkanastha Brahmin community. Community consanguinity is all very important part of history when you're dealing with a genetics issue. She was recently diagnosed with a locally advanced breast cancer at the age of 38, and she had a significant family history of breast cancer in her mother at 40 and ovarian cancer in her Masi, her maternal aunt, at 55. So this is what the pedigree chart looks like. The word proband is the term used for the index case. They're usually the patient sitting in front of you. And the cases in red are the ones who had cancer. So that's her mother, breast cancer at 40, alive and well, and her Masi, who is no more, ovarian cancer at 55. Now, needless to say, when we have young patients or any patient, woman with breast cancer, the first and most important issue in her mind is, are my children safe? And needless to say, even for her, she had 2 children, a 3-year-old son and a 7-year-old daughter. She was very concerned about them. And she has 2 siblings, a 35-year-old sister and a 30-year-old brother. So she turned out on biopsy to have an IDC, a high-grade IDC, and it was triple negative. So given her age, given her histology, and given the family history, this was screaming to us as a HBOC, a hereditary breast ovarian cancer. Now, of course, she was sent for genetic counseling, and she gave her sample for the blood test for testing for BRCA1, 2, and TP53. These are the 3 most common highly penetrant genes responsible. And the test takes 3 to 4 weeks to come in. So she obviously was not going to wait that long to start her treatment. And she started off on neoadjuvant chemotherapy first. So let's just have a quick word about BRCA1 and 2. These are 2 genes which gained a lot of popularity after the Angelina Jolie case happened. And these genes are present in all individuals, men and women. They are good genes. But when they are defective or when they have a mutation, then it leads to a 50 to 70% lifetime risk for developing breast cancer in women, which starts after the age of 22. And a 40% risk for ovarian cancer, which starts a little later. The risk starts at 35 to 40. Now, for men, they have a much lesser risk, but they do have a significant risk for male breast cancer and prostate cancer. And this is an autosomal dominant condition, as I mentioned earlier. Now, this graph, which is in the handwriting of my professor, Dr. Rajiv Sareen, very nicely shows that as the lady is getting older, her risk gets significant at about 22, and the lifetime risk increases to about 70%. The risk plateaus off at about 55 to 60 years of age. And the interesting thing is that once they have had cancer in one breast, there is a risk for developing second cancers in the opposite breast, contralateral breast cancer, to the tune of 40% risk, which is also very significant. And we'll talk about that in the slides to come. And the graphs which you can see lower are for male breast cancer and prostate cancer, where the risk is much less, in the tune of 10 to 20% only. So you must keep in mind that when you have a case like this lady that I mentioned, 38 with a strong family history, however, I said it was screaming HbOCS, but it is just suspicious until it is proven. So you must go ahead and evaluate. And how to do so is via a blood test, which a most common technique is NGS, next generation sequencing, where you can choose between the number of genes that you want to cover. But BRCA1 and 2, like I said, are the most common. The result takes about a month to come in, and we don't always have clear results. So you could have a clear cut positive, you could have a clear cut negative, or you could have something called as a VUS, a variant of unknown significance, where you have a mutation but you're not quite sure whether it is pathogenic or not. It's almost 15 to 20% of the cases we end up with a VUS, and we have to deal with it in an individualistic manner and interpret it with caution. This was an interesting paper which I came across, which showed that as now when NGS is getting more and more common, people choose to test more and more number of genes. It sounds very attractive to test the more number of genes, but the more number of genes you test, the higher the chance of you ending up with a confusing result, which is often very frustrating for the patient and the doctor. So in this paper, it showed that with 25 gene panel, there was a 30% chance of VUS, and that jumped to 88% if you test 42 genes. So what kind of test you order also matters. Now, this lady's genetic report came out, and it turned out that she did have a germline pathogenic mutation in the BRCA1 gene, which was classified as the DEL 185AG. It's also the founder mutation in Ashkenazi Jew community, and which is very commonly seen in the Konkanastha Brahmin community in Maharashtra. So that was an interesting point which I wanted to bring out. Now, this lady completed her neoadjuvant chemotherapy. She had an excellent clinical response, and she she chose to undergo a mastectomy. So she underwent an MRM on the left side and a contralateral prophylactic mastectomy on the opposite breast with bilateral reconstruction. And in the same surgery, in the same sitting, she also had a bilateral risk reductive salpingo-oophorectomy. The histopathology showed that she had a complete pathological response in the breast. All nodes were negative. The ovaries and the fallopian tubes were normal, and her opposite breast showed some low-grade DCIS without any other invasive focus. And the important point here is that when you are operating for a patient for a risk-reductive salpingo-oophorectomy, it has to be done very carefully, especially the pathology has to be dealt with in a very careful manner, because there are women who you think you're doing a prophylactic surgery, but they may have an occult primary already in the fallopian tubes, where we know ovarian cancer originates. And if one is doing this surgery, then the histopathologist plays a very important role as well. So since we're talking about the management of HbOCS, a quick mention about the choice of surgery when you're dealing with such patients. So the scenario which I've shown you in this case, where we already knew that the patient had a mutation when she went in for her surgery, is actually not so common. A lot of patients may not have locally advanced cancers. They want surgery up front. They are operable. And at the time of surgery, we don't know whether they have a mutation or not. They can't wait for a month for the result to come, and we have to make this decision along with the patient's choices. And the answer for conservation versus mastectomy in such suspicious cases is that breast conservation, so there is ample number of studies now which have been done which show that breast conservation is safe even for BRCA carriers, and there, albeit a small risk of ipsilateral breast tumor recurrence. They have a slightly higher risk of recurrence in the conserved breast, but this does not impact their survival. So as long as you have a patient who is going to be compliant, has been counseled well, if she's young, if she's willing to if she's keen for a breast conservative surgery, then there is no hard and fast rule to remove the breast at all. So that is one point I wanted to bring out. Of course, if the breast is conserved, then radiation is required as well. So these are all points to keep in mind. Now, another very important question is that, is it really necessary to remove the ovaries? So there is RRSO surgery, the wrist reductive salpingo-oophorectomy. How necessary is it really? And the answer is that it is very important, because this risk of ovarian cancer is significant, to the tune of 40%. Ovarian cancer is usually asymptomatic until advanced stages. As we all know, it's not a very easy cancer to treat. Outcomes, are not very encouraging. And USG, however good, USG you're doing, however often you are doing CA-125, these are not sensitive or specific for early detection. So the only effective way of reducing risk or risk management in a BRCA1 carrier is to do an RRSO after the age of 35 or 40, depending on which gene it is, after she has completed her family, she's adequately counseled and consenting to the surgery. Lot of issues when you're planning for an RRSO. So when should it be done? So say you have a healthy lady who tested just because she hasn't had breast cancer, but she has a family history. She did her test and she turns out to have a mutation. She's 38 and she has one child. All right. So when do you offer the RRSO? She's keen to have two children. So she's already in this risk group. So there is no straightforward answer to this. This is where the patient, the oncologist, the genetic counselor, everyone has to come together and really help the patient make that decision. So the timing of the surgery, even with respects to treatment, and what to do when you have a confusing result. So these are all very pertinent issues which we deal with often. Now, for patients who don't wish to undergo prophylactic surgeries and prefer surveillance, that's a very valid option for breast. And that is done in the form of mammography and MRI alternatingly every 6 months. So if she's getting a MRI in Jan, she will get a mammography in June. And so every 6 months, there is some imaging happening of the breast along with a 6-monthly clinical breast examination. So this is also a very effective way of preventing or catching early breast cancers in such high-risk individuals. People who are too young to undergo an RRSO or refuse to do so, of course, should undergo ultrasound and CA-125 regularly every 6 months. So we've dealt with the proband, this lady which I discussed. What about her family? So her children do not need to be tested now. Like I mentioned, BRCA shows itself if you get cancer, it would be in adult life. So nothing till the age of 18 years for the children. And that too, it would be after genetic counseling of the children. Individually, not all people want to know their status, their BRCA carrier status. I've had a number of young women who prefer not to know until they have completed their families, because it has a huge psychological impact on their life. And she had two siblings, a 35-year-old sister and brother, who both also we have to evaluate to see whether they share the mutation. So we've spoken about how to manage the risk for breast and ovarian cancer. And we spoke about family members. Reproductive counseling is also very important. So when you're dealing with a patient who you suspect or has a hereditary breast ovarian cancer syndrome, reproductive counseling in terms of whether to have children or not, and when to have children, because sex determination is illegal in our country. So, there is a 50% chance that a carrier will have a girl. There's a 50% chance that the mutation will pass on. But this is not a devastating syndrome. Like I said, the risk starts all the way in adult life. And in the years, technology is improving so fast. So patients who are seeing today, if they have children now who are BRCA carriers and they are women, it's going to be after 22 years that they enter the risk category, and hopefully, gene editing, and we'll have all kinds of technology. So if you have a woman who has a mutation, it is not, I never discourage women who are BRCA carriers to have children, of biological children of their own. So that's a point I wanted to bring out. And of course, the treatment implications. So I'm done with discussing BRCA, and I just wanted to touch upon a few other syndromes which are much less common, but you should know about them. Lynch syndrome is something which is also seen in the clinic quite often. It is to do with colorectal malignancies mainly. They have a 70 to 80% chance of colorectal cancers in adult life, but the women with Lynch syndrome have a 40% chance of uterine cancer, endometrial cancer, which is significant. And they also have a smaller risk for breast and ovarian cancer. So if you have a patient with a family history of colorectal malignancies, endometrial cancers, young endometrial cancers, do think of Lynch syndrome as well. Lee-Fraumeni syndrome, TP53 gene mutation, is a devastating autosomal dominant syndrome where the individuals, men and women with the syndrome, are at a high risk for almost any kind of cancer, but the most common being breast, soft tissue sarcomas, brain cancers, leukemias, and lymphomas. Most certainly, these people will have some family history, and it's, like I said, devastating. This syndrome can also show cancers in childhood. So if you come across someone with a family history of soft tissue sarcomas and leukemias, then it really has to be dealt with immediately, because even children can get cancer with this syndrome. This was an interesting case which I wanted to share. So this lady actually had early breast cancer, and she was operated with a mastectomy. She had a single lymph node positive or pathologically, and the opinion was for whether to give radiation or not. So when she walked into the clinic, I noticed she had a very peculiar phenotype. She had pulsating exophthalmos. She had a sphenoid wing dysplasia. She had multiple cafe au lait macules, axillary freckling, and little neurofibromas all over her body. So I immediately thought of NF1, neurofibromatosis type 1. And, she gave a positive family history that she had some relatives like this, and even her son had the same kind of skin lesion. So I clinically diagnosed it as NF1. And these women are at a high risk for developing breast cancer, and also are very sensitive to radiation and second malignancies because of radiation. So because she had not a very advanced breast cancer and a mastectomy, I chose not to give her radiation, because her risk from the radiation was probably higher than the therapeutic advantage. So this was nice, because the genetic knowledge helped me make a clinical decision for the radiation as well. So there are other syndromes which you have to keep your eye out for. This was an interesting case. Also, this lady came into the hospital with an intestinal intussusception with an acute abdomen, and the surgeon immediately noticed that she had hyperpigmentation of the oral mucosa and the lips. And her daughter, this is a photo of her daughter, who also had a very similar kind of picture. And this is very classic of something known as Peutz-Jeghers syndrome, in which they have a higher risk of breast cancer. So we have informed the family, and they are now on surveillance. Now, I've compiled a list of common misconceptions, questions which I very often get asked when I talk about this topic. So I'll go through them one by one. Very often people ask me that if there is cancer from both sides of the family, then does it mean that the individual will have a double risk of cancer or higher risk of cancer? So no, 1 + 1 is not always equal to 2 when you're talking about genetics. The cancer history has to be from the same side of the family or through in blood relatives. So if there is one single case from the mother's side and one single case from the father's side, it doesn't mean that the offspring has a double risk of cancer, not at all. Gender, looks, personality have nothing to do with these tumor suppressor genes or these cancer genes. So there is no way of guessing whether female offspring will have the BRCA gene, or somebody who looks like the mother will have the gene. Until you do the genetic testing, there is no way to know. When one is taking family history, it's very important to be mindful that often patients confuse a uterine cancer with a cervical cancer. So it is all Pishvika cancer for them. But you need to differentiate, because cervical cancer is it is not, hereditary. We all know it is viral in origin, and uterine cancer is completely different. So that's something to be mindful of. People often think that it skips generations, but that's not the case. Like I said, most of these are autosomal dominant. They don't skip generations. Sometimes patients who are very young, they're sent for genetic counseling. They feel that how can I have a genetic syndrome when there is no family history? There is no other member in my family. So it is not necessary that there is always going to be a family history. The reason for this is that the mutation A, it has to start somewhere in the family. B, very often, if we're talking about the BRCA gene, if it's coming from the male side of the family, then men have a very low risk of getting the cancer themselves, but they will pass it on with a 50% chance. So if it's coming from the father side of the family, you may not see any cancers, but then you would have somebody affected at some point. So that is the reason. And like I said, it's not always 100% chance of getting cancer. So you may have somebody who has the gene and goes through their whole life without ever getting the cancer if they're lucky. And the last misconception is that genetic testing is terribly expensive. It is not. We have a number of ways that we can help patients, so please do reach out. Now, other issues which are worth thinking about when you are talking about this topic of genes is confidentiality. It's very important. It's an extremely sensitive issue. The responsibility to inform patients about this condition and advise them, but also to make sure that they don't get discriminated against. So you have to inform the patient, and they need to be aware that coming to know about a genetic condition should not lead to insurance discrimination or employee discrimination. There are huge social implications to coming to know that you have a hereditary syndrome, especially for young women who are in the formative years, deciding about marriage, deciding about children. It can have very, very huge implications on marriage. These are things to keep in mind. Consent has to be done very carefully. Consanguinity is important history to take, and it's not at all uncommon in our culture. And adoption and paternity is also an interesting point. So that's, I had an interesting case recently where I had a young boy who was brought to me with a very high index of suspicion for a genetic condition called FAP, where he had thousands of polyps in his intestine. So it was most certainly a genetic condition. He had a rectal cancer at the age of 13, but he did not know that he was adopted, and they did not know his biological parents. So the patient in front of me did not know. I was luckily informed by the family in time, and I could handle the whole issue sensitively. So these are things, paternity and adoption are important issues. So the final kind of take-home message that you should take away from this talk of mine is that please take family history in detail, always, especially when you are dealing with a case of breast cancer. If there are any red flags, please offer genetic counseling. So not every genetic counseling ends in a testing. Not all patients require testing, but no testing should be done without counseling, because as I have mentioned, it can, there are a lot of things that can go wrong. And a lot can be done for the patient and their family for risk reduction, and for them to lead fruitful lives if the issue is handled with care. And I'd like to leave you with an image of an iceberg, because what we know right now in this field of cancer genetics is just like the tip of an iceberg, and there's just so much below the surface that we need to yet understand and discover together. So thank you very much for your kind attention. I leave you with an image of my contact details. I'll be happy to answer questions, and please reach out if you all have patients that require genetic evaluation, or even if you all have a personal history and any personal kind of doubts regarding yourselves or your families. I'll be happy to reach out and to help out. Thank you so much, and over to the organizers.
Thank you so much, Dr. Mansi. That was really nice. And, every time I listen to you talk, I learn something new about cancer genetics. Really nice. So we've had a good discussion on it. And I just have a couple of questions for you from the audience.
Sure.
So first is, what is the difference between familial and hereditary cancers?
So that's a very good question. Familial cancers are cancers which are seen clustering in families, and they need not be hereditary. So if a family has a common environmental factor, if siblings are growing up with a common carcinogen around them, then there will be a familial clustering of cancer. Or if a family is living in an area with near a common carcinogenic source, so you can have familial cancers without being hereditary. So they are different. So hereditary cancers are familial, but not all familial cancers are hereditary.
Okay. And do the management guidelines apply to both? Like, as you said, in hereditary, because of genetic mutations, certain management decisions change. Will they also change for familial?
So, if we're talking particularly about breast and ovarian cancer, then most of them, if they are familial, they do have a hereditary basis to it. So, you wouldn't have so much environmental impact causing familial. More often than not, if you have family clustering, they will have something. So the answer is no. It has to be proven. That is the reason I said, until you have, it is just a suspicion unless it is proven. So if you feel it is familial, we have to confirm that it is hereditary before we apply these principles of management, especially if it is going to be surgical prophylaxis for the patient. So that is why, as oncologists, we're all very sensitive about timely testing, because you need, even as a doctor, you need the proof of that this is a mutation before you go ahead and do any kind of surgical management. So I would say that if you feel that it's familial, you must check if it is hereditary.
Okay. Another question, Dr. Mansi. A lot of clinicians themselves also prescribe the tests, BRCA1 or 2, when they are suspecting a familial hereditary disease. So is it okay to do that, or should the patient be referred to a genetic specialist? What are the implications?
So I agree, it's becoming more and more common and I think that's great. That just shows that the level of awareness has increased so much. But I still feel that the patient must go through a good genetic counseling before the test is done. And then the test can be ordered after that, for two reasons. Number one is that your patient needs to know certain basic information before they go ahead and even do the test, because the results of the test can be devastating potentially psychologically for the patient. And the doctor may not always be equipped to deal with that kind of implications. Secondly is, like I said, you have a good chance that you'll end up with a result which you just won't understand. So like a VUS, and there you need some sort of expertise. So, please do reach out to any genetic counselor or any genetic clinic before getting a genetic test. Highly recommended.
And is an informed written consent taken before the genetic testing?
Absolutely. Absolutely. So the procedure I follow is, I have my own consent, which I have developed with my own points. And plus, most of the companies which do genetic counseling also have their own consent forms. But like I said, it's important to have your own consent if you plan to do a genetic counseling and testing.
And the first test that is done is NGS, as you mentioned. So if there are problems, you don't get a clear answer, do you do anything else after that?
Yes, so NGS is a kind of a sequencing test which may not always pick up. Although NGS has really become good now, it may not always pick up large deletions or duplication. Means that if you have a huge part or chunk of the gene missing, then your sequencing may not pick it up. And then there are some tests like MLPA which can help detect such lesions, so such mutations. So if you have a case in which you are highly suspecting a mutation but you get a negative NGS, then yes, there are some further tests which we can do before we kind of close the chapter on that patient.
Okay. Thank you so much, Dr. Mansi
Thank you
Munshi.
so much.
Really nice. Thank you.
Thank you. Bye-bye.
Good morning. I hope you all are enjoying the conference. I would just like to mention that we are running a lot of screening camps for women for detection of breast and cervical cancers all over Pune city and surrounding rural areas. And we are also treating a lot of poor women from these places free of cost or very, very subsidized minimal cost. However, we need funds to do these activities. Hence, we have partnered with Keto as on a fundraising platform, and we would request all of you for your donations for these screening activities and helping out the poor patients. Even a donation of minimum 100, 200 rupees will be very helpful. The link is given over there, and if you have any problems, you can contact any one of us, the organizers, and we would be happy to help you. Thank you so much.
So now I'll introduce Anupama. Okay. So my video has to. Okay, can I go live? Okay. So yes, good morning everyone, and I hope you're all enjoying the conference. So now we move on to our next speaker, who's my dear friend and colleague, Dr. Anupama Mane, who's a breast surgeon with a huge experience of 23 years in surgery. She's trained to do breast oncosurgery from Tata Memorial Hospital as well as Germany. She went ahead and did her training in oncoplastic and reconstructive breast surgery from UK Royal Derby Hospital. And she is doing extensive work in breast cancer. We are also together doing a breast clinic, which is a dedicated team of all women at Ruby Hall Clinic. And Dr. Anupama has a lot of publications and a lot of expertise in dealing with breast cancer. So let me welcome Dr. Anupama Mane for her talk. Anupama, over to you.
Thank you, ma'am. Thank you for the kind introduction. Let me start with this topic now. I'll be discussing the spectrum of difficult breast diseases and their management. So this topic has been chosen because there are a lot of clinical situations which are really difficult to deal with. And even after so many years of experience, we find it extremely frustrating. So we would really like to discuss this with all of us, all of our dear colleagues, and see if we can find some solutions and some better management principles for these patients. So I'm not covering the entire spectrum, but only the difficult cases. And I would like to go ahead with clinical case discussions actually. So this is the general benign breast diseases that we see. This is fibroadenomas, fibrocystic changes, ductectasias, papillomas, fat necrosis, lipomas, hematomas, mastitis, abscess, and of course, malignancy. But all of these are relatively okay to deal with. And this is how we investigate them with mammography, sonography, MRI. Dr. Varsha Hardas has already explained about all these investigations. Coming to the pathological diagnosis, we prefer core biopsy over FNAC. And gradually FNAC has become obsolete now. Why core biopsy? Because we can get a more definitive histological diagnosis. We can differentiate between ductal carcinoma in situ versus invasive ductal cancer. That is important in the management of the patient. The type and the grade of tumor, the tumor receptor status, estrogen receptor, progesterone, HER2/neu receptor, all these markers can be determined even before surgery. Then, of course, we can differentiate between high-risk conditions like atypical ductal hyperplasia, Lobular hyperplasia, lobular carcinoma in situ, all these entities are not possible to distinguish on FNACs alone. And of course, even in benign tumors like fibroadenomas, we can distinguish whether they are fibroadenomas, tubular or phylloids tumor. So the finer distinction in the diagnosis comes with the core biopsy. It does not come with the FNAC. Coming to the first case, a young lady with history of several breast lumps on the left side, several years, but recent increase in size of one lump over 9 months. On clinical examination, she had a very large, mobile, well-defined lump measuring 10 by 8 centimeters. That you can see is a very huge lump, and there were no nodes palpable. On sonography, since she was 29, we did not do a mammography, we did a sonography. There were multiple bilateral, different sized, well-defined lumps, but the largest in the left upper outer quadrant was 9 by 8 centimeters. This is the picture of the sonography. You can see the largest lump and with a little vascularity and some clefts and cystic spaces. The core biopsy was done and it came out as complex fibroadenoma. So obviously with the report of complex fibroadenoma, which is increasing in size, we did a surgical excision of this largest lump. She also had many other smaller bilateral lumps. However, all of them did not require excision. They were not growing and they were not painful. But to our surprise, the final histopathology came out as phylloids tumor with borderline malignant potential. Now, this is a little disturbing because it has different implications for the treatment. So currently, we had only removed the lump. However, we needed to remove it with margins in order to prevent recurrence with phylloids. So phylloids is a very difficult condition to treat in the breast, and it has its own spectrum. Phylloids is divided into 3 different types. The benign phylloids, which are okay with excision and they generally do not recur. The borderline phylloids, which have a malignant potential, they have a high chance of recurrence. Almost 30 to 40% of the borderline phylloids will recur. And there is a malignant phylloids also, which can recur as well as metastasize to other parts of the body. So we have to be extremely careful in determining whether this is phylloids and what kind of phylloids this is. The recurrence has to be avoided, and the only way to avoid recurrence with this is to excise it with good amount of margins. Hence, she had to undergo another surgery, which was a wide local excision of previous lumpectomy cavity with a latissimus dorsi flap, because she had a huge defect. We had to cover that defect, and ultimately a flap had to be put into that defect. So as I said, we have to be very careful in determining whether the lumps in the breasts are just plain simple fibroadenomas or they could also be phylloids. So we have to look for history of recent increase in size. On sonography, features like clefts or cystic spaces or high vascularity or lobulations or any other suspicious feature which could, before surgery, tell us that it is likely to be phylloids. In that case, we would prefer to do only one surgery along with the wide local excision of that lump. Coming to the second case, she's a 45 years old lady. She had a lump below right nipple and nipple discharge since 10 days. 3 by 2 centimeters lump. It was well defined, retroareolar just below the nipple, and serous nipple discharge through single duct. Now, coming to nipple discharge, it's very important to determine, is it unilateral, bilateral? Is it bloody or serous, or is it green-brown, milky, mucoid? Is it a single duct or multiple duct? Is it spontaneous or non-spontaneous? And discharge associated with malignancy is usually serous and bloody. So if the discharge is unilateral, bloody or serous, single duct and spontaneous coming out on its own, it is definitely a pathological discharge and needs to be further investigated. This was a mammography of the patient. You can see that shadow behind the right nipple. That was the lump. It's quite well defined. And on sonography, you can see that it is a cystic lump, but it has a solid papillary projection-like tumor on the wall of the cyst. It is quite vascular also. This is another view. And on true cut biopsy, it was a papillary lesion. Now, again, papillary lesion is a very difficult diagnosis. We don't know whether it is a benign papilloma. It could also be a malignancy. It could also be a DCIS, in situ papillary carcinoma, and there is a whole spectrum. And to determine it pre-operatively is very, very difficult for us. And of course, the treatment options also vary. There is VAB resection. Dr. Varsha Hardas had spoken about it, vacuum-assisted biopsy resection. That can be done. That's a simple local anesthetic procedure. Microdocectomy can be done because it was a discharge coming through single duct. Hence, that duct can be cannulated and the lesion removed. And of course, wire localization and excision with margins if you're suspecting malignancy. So for this lady, surgical excision was done and the histopath was benign intraductal papilloma. However, papillomas are not very simple entities. There are two main types of papillomas. One is solitary intraductal, which is common between 30 to 50 years of age. It presents with a bloody nipple discharge, single duct usually. It can also have a very small mass, which is retroareolar, usually occurs centrally in the large subareolar ducts. And the differential diagnosis, of course, is also papillary carcinoma. We have to keep it in mind that it could be a papillary carcinoma, and treatment of this is only microdocectomy. And then coming to the second variety of papilloma, that is multiple peripheral papillomas. It occurs in younger females. It usually presents at breast lump and not as nipple discharge because they are located more peripherally. They could be bilateral and they have a very high local recurrence rate, almost to the tune of 30%. They are also susceptible to malignant transformation because they have an associated epithelial hyperplasia. So that has to be kept in mind. Ladies with multiple peripheral papillomas after excision have to be kept under strict follow-up, 6-monthly follow-up with sonographies or even mammography if required, and biopsy. Treatment, of course, is complete excision with follow-up, as I mentioned. And this is just papillary carcinoma. So with any papillary lesion of the breast, the possibility of carcinoma has to be kept in mind and treatment has to be planned accordingly. Coming to the next case, a 43-year-old lady, she had no complaints whatsoever. She just went for a screening mammography. She didn't even have a family history of malignancy, just a routine screening. And on mammography, on the left side, you can see some suspicious microcalcifications in the central retroareolar region. These are the microcalcifications. A small cluster was there. And now these are also very difficult to treat because you don't know really, whether these are malignant, whether these are benign. And we do an ultrasound to check on this, whether there is an associated mass with this. Probably we can biopsy this to get a diagnosis. However, many times it happens that the ultrasound does not show these microcalcifications and we have to remove these calcifications. So ideally, they should be removed by stereotactic biopsy, but in many institutes, we don't have stereotactic attachments to the mammography machines. Hence, wire localization is another simple procedure that can be done under ultrasound guidance if the microcalcifications are well seen. So under local anesthetic, a wire is inserted into the microcal. You can see the mammography over there with the wire in place that has a Y end and it is near the microcalcifications, and that whole specimen along with the wire is removed. And on the histopath, this patient showed this lesion as low grade ductal carcinoma in situ. All the margins were free, ER/PR positive, HER2 negative. So she underwent radiation and tamoxifen therapy. Now with ductal carcinoma in situ, because it is not invasive, the role of sentinel node biopsy or axillary dissection is not clear. However, with larger tumors which are diagnosed as DCIS on core biopsy, sentinel node biopsy is recommended. Coming to the next case, she's a 33-year-old lady and she was 20 weeks pregnant when she met us. No family history of carcinoma. And she came with a palpable lump in the upper outer quadrant of right breast, 1.5 into 1.5 centimeters. No palpable nodes. Now she is a pregnant lady and we generally don't recommend mammography, but mammography can be done even in pregnant ladies with a shield. And the dose in digital mammography is the dose of radiation is 0.001 gray, which is quite less. And for diagnosis of malignancy, it is important that we need to do a mammogram. It can be done safely. And on ultrasonography, this was the lesion. There was a little bigger lesion, and they were too small. Those arrows, you can see smaller lesions. So this was a multifocal disease in the right breast upper outer quadrant. True cut biopsy was done under ultrasound guidance, and it came out as infiltrating duct carcinoma, ER 30%, PR 40%, and HER2/neu positive. So this was an aggressive disease, and she was pregnant. So how do we proceed further with this? Staging, yes, we would like to do an ultrasound abdomen to check out her liver, her pelvis. Chest X-ray also can be done with abdominal shielding. Now, coming to the role of CT, MRI, and bone scans. MRI can be done in pregnant patients. However, CT scans are contraindicated and bone scans are also contraindicated. And even the MRIs and all can be done without contrast. After the staging, surgery is planned. Surgery can be anything ranging from simple mastectomy with a sentinel node biopsy, or we can do an MRM or a breast conservation surgery. Surgery can safely be done in the second and third trimester. There is no special risk due to surgery. There could be some anesthetic risks because this is usually done under general anesthesia. Histopath report was IDC grade 3 multifocal, largest tumor 1.7 centimeters, and it was of course a node negative disease. And she further went on to take chemotherapy, trastuzumab, radiation. Radiation of course was given. Trastuzumab and radiation was planned so that it could be given after her delivery and then followed by hormonal therapy. So breast cancer is actually most common malignancy in pregnant women, occurring at a rate of 1 in 3,000 women. And pregnancy associated breast cancer is generally defined as breast cancer diagnosed during pregnancy or even up to 1 year after delivery or any time during lactation. Existing data on pregnancy associated breast cancer is retrospective. Most are very small case series. We really don't have very large trials detailing out the management. And there are a lot of oncological issues with these patients. Do the pregnancy and cancer have adverse biological effects on each other? Do treatment delays cause an adverse outcome for the mother? Which treatments are safe during pregnancy? And after breast cancer treatment, would a future pregnancy increase the risk of recurrence? These are very common questions asked by the patients. So to answer one of the questions, what is the outcome of breast cancer with pregnancy? These are actually conflicting views. The table on the left says that survival of pregnant patients with breast cancer and survival of controls without breast cancer, there is no significant difference and they behave equally well. However, the table on the right says that survival of pregnant patients with breast cancer is much less than survival of pregnant patients without breast cancer. So as I said, we have a lot of conflicting views on this. However, there has been a systematic review of all these studies that are there published in literature. And the general outcome of this is that patients are actually behaving same as non-pregnant breast cancer patients, and there is no additional morbidity due to pregnancy. Coming up to the incidence, the pregnancy-associated breast cancer makes up to 3% of all breast cancers, quite rare, but the problem is that it is very difficult to diagnose. And average age at diagnosis is 32 to 38 years, and 90% of the cases present with painless lumps. It's a growing problem, breast cancer diagnosis in pregnant patients, because women are usually delaying childbirth, and both the diagnosis and treatment delays are very common during pregnancy. So these are the features of breast cancer in pregnant women. Most of their cancers are invasive ductal and they are high grade. Lymph node involvement may be there in 40 to 75%. ER/PR negative patients may be 40 to 80%, and HER2 positive will be 20 to 40%. But this is similar to all non-pregnant women with breast cancer less than 40 years of age. Hence, pregnancy itself does not confer a bad prognosis to the breast cancer patients. So there is commonly a delay in diagnosis from 4 months to 11 months. This is important to remember. Hence, if any patient who's pregnant comes with a breast lump, she needs immediate investigations and treatment for that. We have to rule out malignancy because delay in diagnosis is very common, and obviously that impacts on the survival of the patient. Mammography, as I said, can be done. Ultrasound is more commonly preferred modality, the first modality to do. FNAC is not advisable because it is usually hypercellular and very prominent nucleoli due to pregnancy-associated changes. It can confuse between malignant and non-malignant tissues. True cut biopsy is advisable for diagnosis and receptor status. Open biopsy is never indicated. Chest X-ray, as I mentioned, can be done with abdominal shielding, very less radiation dose. Ultrasound abdomen is preferred. MRI, brain, bone, no contrast is given. CT scans are contraindicated. Bone scans are also not indicated. Treatment issues, multidisciplinary approach is essential, and there should be no delay in treatment on account of pregnancy. As I mentioned, surgery is safe in all trimesters. Chemotherapy is safe in second and third trimesters, and radiation therapy is not advisable during pregnancy at all. It is always given last and always given after the delivery of the patients. Surgical considerations, mastectomy can be done as well as breast conservation surgery can be done. There is no contraindication to breast conservation surgery. There might be some increased risk of bleeding and milk fistulas, infections, especially if it is done in the last trimester. And there is some little minimal fetal risk of anesthesia, not too much. It's more in the first trimester. Radiation, as I said, not advisable. Chemotherapy, first trimester is not given. High risk of abortions and fetal malformations. Second and third trimester, the risk is same as general population and chemotherapy can be given. Care of the fetus, of course, during the pregnancy, the treatment is going on, but ultrasound before each cycle of chemo is done to monitor the fetal growth. Preterm delivery, if it happens due to the chemotherapy, lung maturity has to be assured. Vaginal delivery is always preferred. Chemo given after delivery, breastfeeding is not recommended. Breastfeeding has to be stopped. And last chemo is recommended 3 to 4 weeks before delivery so that the body regains back its immunity and prepares for the delivery. So early diagnosis is very important in pregnancy-associated breast cancers, even in lactation-associated breast cancers, and multidisciplinary approach is very important. Termination of pregnancy is no longer required if it is detected during pregnancy. Coming to the next spectrum of cases, these are extremely difficult cases to handle. These are young ladies, third and fourth decade, inflammatory lumps, discharging sinuses, non-healing wounds, recurrent and chronic. These are the common complaints of these ladies. You can see all these are sinuses and non-healing wounds on the breast, very ugly looking, and persistently these small abscesses keep happening. This lady, multiple abscesses healed, but ultimately took about 1 to 1.5 years. This is another lady with similar complaints, and you can see she's undergone surgery on the right side several times to remove the abscesses, the inflammatory lumps, and the size discrepancies also become huge. Another lady, recurrent sinuses, another one. I'm sure everybody has seen these cases quite a lot, persistent recurrent breast infections, and find them very difficult to treat. Diagnosis, of course, the routine diagnostics we use. Ultrasound can give us some diagnosis about the inflammatory lumps or abscesses or sinus tracts, very ill-defined inflammation. Core biopsy is diagnostic, needs to be done, and this can show granulomas with lymphocytes, histiocytes, giant cells with no caseative necrosis. If there is caseative necrosis, this would be diagnosed as COX, and we can start her on AKT. However, if there is no caseative necrosis, this is chronic granulomatous inflammation. but it is likely to be idiopathic and not due to COX. There are, of course, certain other causes that we have to rule out, like sarcoidosis or Wegener's granulomatosis, or a foreign body reaction causing the granulomatous reaction on histopath. There are a lot of other causes which have to be ruled out. After ruling out, if we are not able to pinpoint any cause for that granulomatous inflammation, then it is deemed as idiopathic granulomatous mastitis. Treatment, of course, either we can do an IND if the abscess is just about to burst, or there's a lot of tissue destruction, then IND is preferred. Remove all the pus. The primary excision of the lump, sometimes inflammatory lump needs to be removed. If the disease is less, it is not very acute, primary steroids can be given to control the disease, of course, under cover of antibiotics. Antibiotics are the first things to be started. And sometimes secondary excision of lump is done following recurrence. Other investigations that, of course, we need to rule out is gram stain, AFP stain, fungal stains, aerobic culture. In occasional cases, even anaerobic culture is required, though it is very difficult to take. And for tuberculosis, TB Gold, TB PCR can be done on the blocks, TB Gene Expert can be done on the pus removed from the abscess. All these things will give us an indication as to the cause of the disease. Management, as I mentioned, according to severity, mild cases is expectant. Start on antibiotics, they may just resolve spontaneously. And surgical IND may be required, excision, quadrantectomy, or even mastectomy. In very, very severe and recurrent cases, we might need to even do a mastectomy for her. However, mastectomy for benign diseases and infections is extremely devastating for the patient and should never be recommended as the first line of therapy. Steroids are usually given for recurrent and complicated cases, but steroids give a good result. This is my personal experience that steroids help in managing the inflammation much faster and earlier, and healing is better. Steroids can be given in oral form, or they can be given inside the abscess wall, and it helps in reducing the local inflammation if directly injected. In certain refractory cases, methotrexate and all can also be given. However, that is extremely rare. Now coming to one of the most difficult cases to manage, and that is, of course, malignancy. And you will find that malignancy, especially in young ladies, as in this case, a 23-year-old lady with a history of missed abortion 1 month back, she comes with a breast lump. We really do not suspect malignancy in her. No family history of cancers. And with a missed abortion, we might feel that she might be having some hormonal induced lump because of hormonal changes in her body. On examination, it is a 4 by 4 centimeters left breast lump in the upper inner quadrant and a single mobile axillary lymph node palpable. This is on mammography. You can see that shadow in the upper quadrant over there, upper inner quadrant over here. This is the MLO view. And this is on sonography, and it is quite a large lump, 4 centimeters lump. Biopsy, of course, revealed it to be infiltrating ductal carcinoma, grade 2, and she was ER negative, PR negative, HER2 negative. Please understand, it is very, very important to do ER, PR, and HER2 tests on the core biopsy specimen, because that can determine what treatment we are going to give to the patient. Now, in this lady, since all the 3 receptor status is negative, she is a triple negative breast cancer, very young breast cancer. There is a very high chance of it being a genetic cancer. However, she gave no history of anybody in her family having previous breast or ovarian or any other cancers. Hence, it was very difficult for us to know, but we really suspected a genetic cancer in her. Now, coming to the treatment options, do we do a mastectomy with or without reconstruction? Because she's a small breasted lady with a little largish tumor. She can be offered a mastectomy, but imagine leaving a 23-year-old without a breast. So obviously we should offer her reconstruction, and followed by chemotherapy and radiation therapy. She would need all 3. However, we can also avoid the mastectomy by giving a neoadjuvant chemotherapy first. So this is a very important concept that has come up in breast oncology in the recent years, that giving neoadjuvant chemotherapy first based on the receptor status it will reduce the size of the tumor, as well as it will reduce the micrometastasis, which might be circulating anywhere in the bloodstream in the body, and it would downstage the tumor. So this 4 by 4 centimeter tumor would be downstage to a much smaller tumor, and then a breast conservation surgery can be done, which is considered to be very safe, followed by more chemo if required, or all the chemotherapy cycles can be finished in the beginning. We get the best response, then the surgery is done with a much smaller residual tumor, hence a smaller surgery, mastectomy is not required, and of course the last part of a treatment would be radiation therapy. Again, another consideration in this patient is genetic testing. If she turns out to be positive, should a contralateral breast prophylactic mastectomy be done for her? Because as you can see, she's 23 years old, she's developed one breast cancer, which is little largish. And as Dr. Mansi Munshi explained, that she would be at a very high risk of developing a contralateral breast cancer later on in her life. Of course, even ovarian cancer. So this has to be done in a very delicate manner, very diplomatic manner. She has to be sent to the genetic counselor, and a pre-testing counseling has to be done. Her mental makeup has to be understood. We have to keep in mind that she's a 23-year-old without any children. She's just had a missed abortion. Obviously, she would want to have children. So we have to refer her to a fertility expert, a gynecologist who will guide her regarding her fertility preservation, what should be done. We also have to be in touch with the gynacs. The oncologists and the gynacs have to be in sync regarding starting the fertility preservation procedures. Is it going to cause a delay in starting her treatment? Can we start her neoadjuvant chemotherapy earlier? Will that affect her ovaries? So all these issues come up with these kind of patients. And of course, after keeping all this in mind, discussing and testing, we go ahead, start the oncological treatment. And she was put on neoadjuvant chemotherapy. She received her chemotherapy cycles, and the tumor, you can see the density has reduced in the breast. This is the mammography later on. And of course, then we have to decide whether we need to do an axillary dissection or sentinel node biopsy. And as her node disappeared after neoadjuvant chemotherapy, it makes sense to do a sentinel node biopsy for her. However, it is important to keep in mind that patients who have a large tumor and a positive node at the beginning of the chemotherapy might have a false negative node on sentinel lymph node biopsy later on after chemotherapy. Hence, the chances of nodal recurrence are a little higher. So patient has to be explained that. And this patient preferred to have a breast conservation surgery, but she said no to the sentinel node biopsy, and we did a complete axillary lymph node dissection because there was a little higher risk of false negative lymph node. And a histopath said that she had no residual tumor in the breast and all the lymph nodes in her axilla were negative. So she had a complete pathological response, and this pathological response is actually expected because she's a triple negative cancers. Triple negative cancers are highly aggressive cancers, but because the rate of proliferation is so high, they also respond very well to cytotoxic chemotherapy, and the tumor just melts with the chemotherapy. Hence, they often give us pathological complete response. In fact, amongst all the triple negative breast cancers, almost 40 to 50% of the patients will have a complete pathological response, and obviously a smaller surgery can be done. Anyway, she was followed up by some more chemotherapy and radiation therapy to the breast. This was the lady, upper inner quadrant tumor. You can see initially the tumor was 4 by 4 centimeters. After chemotherapy, it became extremely small, and a small incision, the tumor was removed, and the incision was only periareolar and axillary. And later on, the incision is not even visible. So in short, there have been major changes in surgical approach in treating the breast cancer patients. Earlier, radical mastectomy used to be done. Later on, it gradually progressed to modified radical, in which the muscles were preserved. In radical, the muscles also, the pectoralis major and minor, used to be removed. And in modified radical, the muscles are preserved, but the breast and axillary nodes are removed. In breast conservation surgery, we have now moved on to smaller and smaller excisions of cancers from the breast. along with a sentinel node biopsy. Sentinel node biopsy can actually preserve the axillary nodes also. And why do we need to do a sentinel node biopsy? Because otherwise the axillary dissection leads to a lot of morbidity of the arm. There is swelling of the arm, which is permanent, lymphedema, there is persistent seroma that may be there, and there may be some shoulder movement restriction. So to prevent all that, a sentinel lymph node biopsy in clinically node negative patients, that means early breast cancer patients, sentinel node biopsy now has become a standard of care. Breast reconstruction is being offered more and more to the breast cancer patients now. And any young patient, especially, is always offered breast reconstruction after mastectomy. This can be done primarily or it can be done secondarily. After she finishes all her cancer treatment, also it can be done. And we are moving on to oncoplastic surgery also now. Oncoplastic surgery means that we are removing the tumor with negative margins. That means it is oncological safe, but we are also doing a little bit of plastic surgery. We are putting in rotation flaps or local tissue flaps to see that her breast shape is maintained and there is no disfigurement due to cancer surgery. So I've covered a lot of difficult diseases in this. However, I'm sure there are many other difficult circumstances still remaining where we need to have more answers to all our questions and our clinical dilemmas that we face every day. Thank you so much for your kind attention, and I would be happy to take any questions if there are. Okay, there is a question. Pregnant women with breast cancer, will her child develop any cancer? So no, the child will not develop cancer because the mother had cancer during pregnancy, but the child may have some genes, hereditary genes, which the child may have from the mother, inherited from the mother, and may develop it in the later point in life, but not just because the mother was pregnant and had breast cancer at that time, not because of that, but the child can develop because of the inherited genetic mutations.
Dr. Anupama, we have some questions from the audience. So they want to know about the granulomatous lesions of the breast and how do you treat them? What is the dose of oral steroid? Is it intralesional? And how do we go about it? How do you treat the multiple discharging sinuses? And I also see that it is getting very, very common. Of late, we've got a lot of cases of granulomatous mastitis, and it is really very difficult uh, for such lesions to be treated because, you know, even if you are treating them predominantly, initially you treat them with antibiotics, but they just come back, they are recurring, they come back with very bad deforming actually disease for the breast. And I think not only the patients, but even the doctors find it very difficult to understand how to treat them and how to cure these things. So could you just put in a little bit of highlight and give some suggestions?
So first of all, whenever a lady comes with a breast infection, what we have to rule out is it just a simple periductal mastitis? That means just a bacterial mastitis? Or is it more likely to be granulomatous? Also, is it a lactational or a non-lactational mastitis? In lactational mastitis and abscesses, of course, treatment is very simple. It is because of lactation and stagnation of milk. So we just aspirate the pus and send it for culture and treat her depending on the culture reports. That's straightforward. Non-lactational mastitis, of course, the causes could be different. We also have to rule out whether the lady has diabetes or any other immunosuppressive condition, which could be predisposing her to infection. Now, these infections could be due to many causes. Again, we have to rule out, is it bacterial, is it fungal? And as I said, is it just a simple periductal mastitis, or is it, not in the central location? Is it in the peripheral location? So a good sonography helps in this, because we can see the dilated ducts with the debris and all that. And we get an indication what it could be. We start with the antibiotics. If there is pus inside, aspirate, send for culture. We also prefer to do a core biopsy of the wall of the abscess.
Exactly.
That is very, very important, because that gives us tissue and we can find out these granulomas if they are present over there. And of course, TB, PCR and TB gene expert will help in ruling out the TB. And if, of course, we are not getting any answers, all these tests are negative, and we are seeing granulomas which are non-caseating, then we do come to the diagnosis of idiopathic. Now, once we have this diagnosis, what we need to do is control the acute infection first. So always cover all this. While all these investigations are going on and we are waiting for the reports, we start the antibiotics anyway. So under the cover of antibiotics, and when the pus has been aspirated, only after that we start steroids. We don't start steroids right at the outset. Right. So steroids are started actually in the dosage of 1 milligram per kg body weight. So for a 60-year-old, 60 kgs weight lady, it would be approximately 60 milligrams per day. Prednisolone most commonly we start off with, and we give it in divided doses like a BD dose. So maybe 30 milligram in the morning and 30 in the evening. However, I generally don't like to start with very high doses of steroids, because steroids immediately start showing side effects. There's a lot of weight gain, there is facial puffiness, the blood sugars may increase, and there may be pedal edema and a lot of other side effects. They start off within a week, 1 to 2 weeks, and the lady comes back with all these side effects. So I would prefer to start a lady with a moderate dose, and that moderate dose would be approximately 40 milligram per day, that is 20 mg BD, and then monitor her. Call her after every 15 days and check whether the steroids are having an effect. And important thing to know is, if there is acute infection, aspirate again. If there is pus, aspirate again. Steroids cannot make the pus disappear. Steroids can only decrease the inflammation that is there. It cannot completely reduce the pus. So keep aspirating, give good antibiotic cover, start with steroids, taper down the dose, and it takes at least 1 to 2 months, sometimes even longer, 3 to 6 months for all the lesions to subside completely.
Yeah, so I think you have explained that very well, but the important point here is that they have to be monitored and they have to have repeated sonography. And as you said, that sometimes the pus pockets keep developing at not the same site, but at different sites, and sometimes even in the contralateral breast. And it is very important to let them have the aspirations if needed under ultrasound guidance, and that really helps them heal in a better way. But monitoring these patients is very important, and it cannot, like, it's not a one glove fits all, like, these are all dependent upon the way they present, the age of the patient, and it's multifactorial. So it has to be tailored to that particular patient. So it's not a generalized same treatment for all, is what I understand.
True.
Okay, so let us see if there are some more questions from the audience. But I think you have shown many cases and examples, and it was quite well said, self-explanatory. And we have realized that breast imaging and breast treatment and breast management of breast disease is not very, very simple as it was thought in the earlier days. It's getting more and more complicated. We are facing newer diseases, newer challenges. We are giving them better treatment options. It's not just simple mastectomy that is what we are following. We are trying to, give, as surgeons, you're trying to give them a very good cosmetic outcome. And for all that, also, you need a lot of support from radiologists here. I would like to say that. So, yeah, thank you very much. And I think we can move ahead with our next speaker. And I would want you to introduce our next speaker. Thank you.
So I would like to welcome Dr. Shona Nag to our meeting. Dr. Shona Nag is a very senior medical oncologist from Tata Memorial Hospital, Mumbai. She's completed her training in medical oncology from St. George Hospital, Sydney. And she's currently practicing as Director of Oncology in Sayadri Group of Hospitals and breast oncologist at the Ruby Hall Breast Center. She's a very active clinical researcher and has been a principal investigator for multiple global clinical oncology trials, and most of them in breast cancer. Breast cancer is her special interest. She's also been awarded a number of research initiative awards. And as you can see from this, the Times of India Health Icon Award for her contribution to oncology in Pune. She's a member of several international cancer societies and Indian Collaborative Oncology Network and other medical and pediatric oncology societies, and is on several advisory boards and drug safety monitoring boards for drug development in the country. Inviting Dr. Shona Nag, please, for her talk.
So it's a pleasure to be here this late morning. And thank you, Anupama, for that lovely introduction. It is indeed a pleasure to be working with Anupama and Varsha at the Breast Center and pursuing my area of interest at the Advanced Center for Breast Diseases at Ruby Hall. And I've been given a very tough mandate, and chemotherapy is really the bread and butter of most oncologists. So when Anupama asked me to speak on managing breast cancer without chemotherapy, is it really possible? I had to think a little bit hard on this and realize that we are doing it already in a lot of cases. So what I propose to do over the next 30 minutes is tell you a little bit about breast cancer in India, how our understanding of breast cancer has really improved in the last 2 decades. What is the management for metastatic breast cancer? What is the treatment for early breast cancer from a medical oncologist point of view? And what is then the future of breast cancer care? So just to give you a few statistics, and this is a source of GloboCan, which is supported by the WHO, and it gives us statistics worldwide about cancer, new cases, and prevalence and mortality. And the number of new cases in India in 2018 amongst both sexes was as high as 1.1 million cases, and 14% of these were actually breast cancer. So we make up 6% of the world's new cancer cases every year and 8% of the cancer deaths. And if you look closely at the figure that I've shown here, you can see that whether it's male or female, breast cancer is the most common cancer in our country, and it makes up 14% of all cancers that we see. If you look at the breakup amongst women in 2018 across all ages, again, 1 in 4 women walking into our clinic will be diagnosed with breast cancer. So the prevalence or the incidence is around 27%. This is followed by cervical cancer, which has dropped now to second place at 16.5%. And in the third place, funnily enough, is ovarian cancer, which has shown a marked rise in the last decade. So this is what our epidemiology currently shows. Another sad fact about breast cancer in India is that the incidence may be 1.5 to 2 lakhs, but the deaths are half of the new cases that are being diagnosed. So almost half the women diagnosed are dying, and this can be attributed to a late diagnosis and the fact that some of these women may not get access to proper treatment. So a few more facts. The age-specific rate for breast cancer is 35 per 100,000 in urban India. It varies across region and ethnicity. It's the highest in the Parsi community, as high as 48.3 per 100,000. And you must remember, India is a country of young people, and premenopausal patients constitute almost half. As per the ICMR data, breast cancer is most common in all the urban registries, and the incidence has been consistently increasing. This is what is very worrisome, and it is estimated to have risen by 50% between 1965 and 85. And now the rate of rise of incidence of breast cancer is almost 1 to 2% per year. And this is seen across all regions, across all age groups, but more so in the younger age groups. The incidence of this disease has been consistently increasing. And if you look at the red box below, a significant proportion of Indian breast cancer patients are younger than 35. And this proportion varies between 11% at Tata Hospital and 26% at centers in Lucknow. So we are worried about the young breast cancer population. And they, as Anupama already pointed out so nicely, are a very difficult population to treat, with a lot of complex issues about fertility, genetic testing, and missing the diagnosis. So what about the disease stage? If you look at the US, only 7% have stage 3 and 5% have stage 4 at diagnosis. But in Asia, this fraction is far higher. It can be almost 25% as discovered or as noted by the Tata Memorial Hospital. So 1 in 4 women walking into our clinics with breast cancer can have locally advanced breast cancer or stage 4 disease. And just to put it in perspective, the average tumor size at diagnosis is 4 centimeters versus 1 centimeter or less in the US and other parts of the West. So they have mainly screen-detected cancers. We have palpable lumps. And this is something that really needs to change. What about understanding breast cancer? So very, very importantly, and I think even as gynecologists, you must be aware that breast cancer is just not one disease. In fact, it's a whole spectrum of diseases. And to put it very simply and clinically, we divide breast cancer into 3 clinical subsets according to the receptor status and the expression of various receptors. stands for estrogen receptor. 50 to 60% of women express estrogen receptor, so they are ER positive breast cancers. This figure in the West is higher, it's almost 70%. Then you have the subgroup which is HER2 positive. They express HER2 receptors. This makes up 15 to 20%. And finally, there is a group that does not express any of the above receptors, no estrogen receptor, no progesterone receptor, and no HER2 receptor. And these make up the triple negative aggressive population. This makes up 25 to 30%, 29% in our data, which we just completed in a large study, compared to only 15% in the West. And this could be probably because, again, our population is much younger. Now, why does this subtype matter? And why have we divided breast cancer into these 3 different subtypes? So based on these receptor status, we are able to predict the clinical outcome differentially and also how they respond to treatment. So for example, an ER-PR positive patient will respond better to hormonal therapy than to chemotherapy. A HER2 positive patient will not only need chemo, may need hormonal, but needs what we call anti-HER2 or antibody treatment. And the third type, which is triple negative, only benefits from chemotherapy. And today, of course, we have immunotherapy also being used for this subgroup. What are estrogen receptors? So they are just nuclear receptors, which are found in the nucleus of the cancer cell, and they stain dark brown. So on your left-hand side, you can see a strongly ER positive patient. It is also not only prognostic, but predictive, predicting response to hormonal treatment. These patients normally are older, they have a slower rate of disease progression, and they suffer very late relapses beyond 5 and 10 years even. And then on your right-hand bottom, you can see a ER very weakly positive tumor. These patients don't respond that well to hormonal therapy, and they have a more aggressive course of disease. This is the HER2 receptor. On your left side, you can see a normal cell. We all have HER2 receptors on our cell. And we have between 20 to 50,000 receptors on our cell surface. And HER2 targeting, that means when the ligand binds with the receptor and communicates with the nucleus that you can see inside for certain cellular functions, is also required for normal heart functioning. So it is used as receptors are part of the physiological process. But when these receptors get amplified 100-fold, 1,000-fold, on your right-hand bottom side, you can see cells overexpressing HER2. These constitute 15 to 20% of breast cancer, and they have high HER2 overexpression, and untreated patients have a highly aggressive course. They die very quickly and they develop brain metastasis very early on. So this is what it looks like on pathology. You can see this lovely HER2 immunohistochemistry staining. Immunohistochemistry stains the protein, that is the receptor protein present outside the cell. And you can see this nice, uniform, complete brown staining of the membrane. These are all HER2 positive cells. Another way to diagnose HER2 positivity is to look at ISH, which is in situ hybridization, which actually looks at the HER2 gene copy number, the amplification, as compared to the green signals that you are seeing, which is the normal chromosome 17. HER2 is found on chromosome 17. So the pink dots you are seeing are the HER2 genes. So they are highly amplified. And we look at the ratio of pink and green, and here you can see it's clearly more than 2. So this is a HER2 amplified patient. So knowledge of the cancer cell and genetics and genomics has really grown over the last decade. And this is what we knew about the cancer cell in 1975. And even 10 years ago, this is what the jump has been. So knowledge about cellular pathways, what makes cancer cells grow and proliferate, what makes them invade and metastasize, what are the different proteins involved, the enzymes involved, the different pathways involved in cancer growth and proliferation has really added to our knowledge and our understanding of how to treat these cancers. So if you just go back to the 1920s and up to 1970, for 50 years, we only fell back on traditional morphology and pathology. Then in the 70s and 80s in breast cancer, we started checking for the estrogen receptor. In the 80s and 90s, where the HER2 gene was discovered, we included ER, PR, and HER2 as a routine immunohistochemistry as on the tumor specimen, core biopsy, or the tumor. In 2000, we have moved from just checking out proteins. You know, there is a central dogma. DNA gives rise to RNA, gives rise to protein. So the DNA, once it converts to RNA, that is the gene expression. And it is the RNA, when it is functioning properly, that forms the protein. So we have now we are looking to identifying different gene expression patterns in patients. The protein may or may not be expressed, but when the gene is expressed, we get certain information on how to treat or not treat. Now, beyond RNA, we've gone backwards and we are now actually sequencing the entire DNA or the exome of the patient. That is the active DNA component. And we are able to get an entire tumor genomic landscape, which tells us, yes, this mutation exists. Yes, this copy number is altered. And depending on that, we have new targeted therapies. So science has come a really, really long way, and it is now being translated to the bedside. And just to tell you that now, when I told you there are 3 subtypes of breast cancer, here in this figure, you can see what is called a heat map. The red bars that you see are genes that are overexpressed. The green bars you see are genes that are underexpressed. So we have different molecular subtypes now of breast cancer: luminal A, luminal B, HER2 enriched, basal, normal. And these are now further divided into many, many more subtypes. So it's important to remember that the classification of breast cancer is greatly evolving, and it evolves every day to further and further subtypes. And how this helps us is each subtype can be treated differently, and we are finding new and newer treatments for each of these subtypes. So we now personalize treatment according to the subtype, whether it is ER positive, HER2 positive, or triple negative. These subtypes help us make treatment choices in both metastatic and early disease. Many of the treatments we use for these subtypes are not restricted to chemotherapy. Some of the treatments, as I will demonstrate with a few cases, do not include chemotherapy at all. And instead of chemo, we use hormonal therapy and targeted therapy in the form of small molecules, anti-enzyme molecules, and in the form of antibodies. So chemo, you all aware, has both short and long-term side effects. The short-term side effects are neurocognitive, stomatitis, fatigue, nausea, vomiting, diarrhea, bone marrow suppression, sepsis, alopecia, which is something our women don't tolerate well or don't accept well, cardiac dysfunction. Secondary cancer can be a long-term side effect. Premature menopause, infertility, is always troublesome. And finally, a persisting neuropathy. This really affects the quality of life. It affects the family life because the carers are also very, very stressed out and have to take time off work. And the working life of the patient is greatly impacted during chemotherapy, and we have long absences and resignation for health reasons. So overcoming the shortcomings of chemotherapy, we have moved to a different era. And I'm going to talk first about metastatic breast cancer. So 10 to 15% of women in India have metastatic disease at presentation. This is a lot as compared to the West. We reserve chemotherapy for patients with triple negative disease who have life-threatening symptoms. For example, you have liver metastasis with liver dysfunction, raised enzymes. You have widespread lung metastasis causing a low respiratory compromise and low SpO2. Or you have a bone marrow involvement due to extensive bone metastasis. That's where you want a quick response. That's where you will jump in with chemotherapy to get the patient stabilize the patient very quickly. The sites of metastasis vary on the subtype. As I mentioned, a triple negative tends to go to the lung, liver, and then the bones and the brain. The ER positive tends to stick to nodes and bone. The HER2 positive likes to go to the brain and all the other organs. With correct treatment and with good treatment today, ER positive and HER2 positive patients can live for an average of 4 to 5 years, even with stage 4 disease. And survival, which 25, 30 years ago at 5 years, which was 5%, is now up to 25% for stage 4 breast cancer. So the first case I'm going to talk about is a 72-year-old diabetic and hypertensive lady who had a high BMI and presented with a huge mass in the right breast. It was stuck to the muscle below, and she had ignored it for 8 to 10 months because it was not painful. On examination, it was a 10-centimeter mass with skin involvement, palpable axillary nodes, and a PET scan was done to stage her, and you would do one in such a case. And it showed metastasis in the bone sites, in the spine as well. A biopsy was done from the breast lesion. It revealed an invasive ductal carcinoma. The estrogen receptor and progesterone receptor were nicely, strongly expressed, and she was HER2 negative, so she is under the subtype of ER positive breast cancer. Her tumor was a grade 2. So this was her picture. So as you can see, this is all the tumor. It looked pretty horrendous in real life. This is normal lighting up the brain and the heart because of the high metabolism in these areas. And here is a nice picture of the breast. You can see the tumor is very, very inside. It is stuck to the chest wall almost with nice 2 axillary nodes, which can be seen. So because she was ER positive, she was started on hormonal therapy with oral targeted therapy, palbociclib. This is a relatively new drug. And if you look at the response, this is the response after 2 months of treatment. You can see that the FDG avid mass has become negative on treatment, and the axillary nodes have also lost their avidity. The mass, of course, remains, but once the avidity goes down, you know that the tumor is undergoing necrosis and is killed, and she's currently doing very well on treatment right now. This treatment is extremely well tolerated, unlike chemotherapy. The second case is a premenopausal lady who presented with a right breast lump, 4 centimeters with axillary nodes. Again, a core biopsy revealed an estrogen receptor of 90%, progesterone of 70%, and the PET scan showed bony metastasis, unfortunately, and small lung nodules. She was initially started on a GnRH analog to suppress the ovarian function because in metastatic premenopausal ER-positive women, the first step is to make them postmenopausal. And later, she was then subjected to a lap salpingo-oophorectomy. Her genetic testing was negative. She was begun on hormonal therapy and oral targeted therapy with a similar agent to the previous lady. not palbo, but ribociclib, belonging to the same family of drugs. And we did her scans after 3 months to assess the response. In spite of having small volume lung nodules, we decided to avoid chemo because she was not symptomatic for any of the lung nodules. So this is her lesion in the sacra, which you can see, which has literally completely disappeared after 3 months of this hormonal and targeted therapy. There was a deposit in the scapula, which has also disappeared. That's her right breast lesion. That is virtually gone. And so also the axillary nodes, and so also the lung lesions. Now, she will continue on this therapy for a number of years before she progresses, by which time we will probably have a second-line hormone therapy ready for her. So the history of hormonal therapy for breast cancer dates back to the 1890s, where Sir George Thomas Beatson, a very fine surgeon, first reported and raised the concept that ovaries may be a cause of the cancer of the breast. What he meant was estrogen was one of the causes of breast cancer proliferation. And he actually treated 3 patients with metastatic breast cancer who must have been ER positive. There was no way of testing it in those days. And he actually removed the ovaries in all these 3 women. And one of them went on to live for 30 years. The second one went on to live for 10 years. So he really performed the first endocrine therapy for metastatic breast cancer. Since then, we have had a host of drugs. Tamoxifen is something you are all conversant with, started off in the 1970s. We then moved to the aromatase inhibitors from the 1990s onwards. Then we got a new drug called fulvestrant in between 2000 and 2005. This is a selective estrogen receptor degrader, and it is a complete agonist, unlike tamoxifen, which is a partial complete antagonist compared to tamoxifen, which is partial agonist. After that, there was a gap between 2000. It was not till 2015 that we got this first group of targeted therapies for ER-positive breast cancer, palbociclib, which was used in the first case I demonstrated. And what are these agents exactly? So if you all know, you have the estrogen receptor. The estrogen receptor is located in the nucleus, but when estrogen combines with it, it comes out into the cytoplasm. This estrogen binds with the estrogen receptor, it gets relocated into the nucleus, and thereby it excites cellular proliferation through what we call the cell cycle. Now, the cell cycle is controlled by certain drugs called certain proteins called cyclin D1 and the CDK4/6 group of enzymes. This drug that I showed you, palbociclib and ribociclib, is nothing but an inhibitor of the CDK4/6 enzyme, and it prevents the cell cycle from moving ahead. Combined with hormonal therapy, it is like a double whammy for the tumor, and it causes cell cycle arrest and ultimately cell death. So this is how these agents work. The third case I'm going to discuss that we treated without chemotherapy recently is a fit 75-year-old who presented with a 3-centimeter lump in the inner quadrant of her left breast. The biopsy revealed a breast carcinoma, which was ER positive and HER2 positive. Remember, I showed you the HER2 positive tumors. So this is one subtype. And so she had HER2 positive disease. Her PET scan was done and it showed a solitary lesion in the liver. The patient was adamant she did not want any chemotherapy. She was started on what we call dual anti-HER2 therapy. We did not use one, but 2 antibodies, trastuzumab and pertuzumab for her, along with oral hormonal letrozole, because she was also estrogen receptor positive. The response to treatment was assessed after 4 months. So if you can look, this is February 2020. This is her breast lesion with all these nodes, and this is her solitary liver metastasis. Fast forward to 4 months later on treatment, and lo and behold, the liver met has disappeared, and so have the breast and axillary lesions. So she continues to be on this treatment as of now. She's now taken a break from the antibody. She will continue hormones alone. So she's received almost a year with very, very little toxicity and absolutely no hair loss. And if her disease should ever come back, we will just reintroduce the antibodies again. You could. And this is another lady which had brain metastasis. and she completed antibody treatment for HER2-positive disease. And what I would like to show you is that for this lady, we had radiated her earlier, but her brain mets came back. We didn't give her chemotherapy. We gave her what we call an antibody drug conjugate, which is trastuzumab with chemotherapy embedded in it. And this is a very, very elegant drug called ADC. And this is going to be the future of cancer care. And she has been on it, and we've actually shown a reduction in the brain metastasis. For early breast cancer, there are also certain situations where we avoid chemotherapy. And we try, as Anupama mentioned, to prevent micrometastasis with our treatments. We look at tumor size, axillary node status, we look at the ER, HER2, and we always take a call, what is the risk of dying from cancer and what is the therapeutic benefit from chemotherapy and what is the toxicity. And we have a lot of tools to predict who does and does not need chemotherapy. Lack of time, so I cannot go through this. There are a lot of genomic tests that we can do. And there are ladies with, and I will just quickly come to the conclusion, many with a low risk of recurrence, ER positive, node negative, which we avoid chemotherapy. Elderly women, also we can avoid chemotherapy. However, most triple negative breast cancers need chemotherapy. What is the future? Metastatic breast cancer, move away from chemo and ER positive and HER2 positive cases. Focus on oral targeted agents, as I've shown you, and antibody drug conjugates. That is the future. In early breast cancer, define the risk of recurrence and spare chemotherapy to those with a very good prognosis, and de-escalate treatment in some cases where we give shorter chemotherapy and we omit drugs like anthracyclines. Thank you very much for your attention.
Thank you, ma'am. That was a really informative talk. And there is a question from the audience. Is hormone therapy as efficacious as chemotherapy? Efficacy-wise, not anything else.
So the point of my whole discussion is that hormonal therapy is really the first targeted therapy was used. Okay, so a person who is strongly expressing the estrogen and progesterone receptor will benefit more from hormonal therapy in terms of overall survival than a person taking chemotherapy for that same subtype of tumor. So chemotherapy won't work as well. Probably the survival benefit will be less, and the survival benefit and response rates with hormonal therapy will be better for ER positive and PR positive tumors. The only caveat here is, in any situation requiring a quick response, we use hormonal therapy later, we use chemo first. But with the targeted agents that I've shown you, palbociclib and ribociclib, you can get responses like chemotherapy when you add them to hormonal therapy. So literally in 2 weeks and 3 weeks, we are getting responses in these tumors. So there's really no need to use chemotherapy in patients who have metastatic disease, are not in a visceral crisis, and are expressing ER and PR.
Okay, another question, ma'am.
Yes.
Are there any chemotherapies which do not cause hair loss in breast cancer?
Yes, so I think that's an excellent question. So there are chemotherapies that don't cause hair loss. One is the older CMF, if you remember, the cyclophosphamide, methotrexate, and 5-FU combination. The problem is because it is so difficult to give, it's first day and 8th day every month for 6 months, it has been replaced by 3 months of anthracycline, which cause hair loss. So you've traded off no hair loss and longer duration, and mucositis probably is a side effect for hair loss and shorter treatments. All right. Then there is an oral drug called capecitabine, which we use very often for metastatic breast cancer. This does not cause hair loss at all. It's so funny that most breast cancer chemotherapies like anthracycline and taxanes cause hair loss and are used in a lot of women with breast cancer. But there are other diseases like colon cancer where you use regimens like Folfox, which don't cause hair loss at all. And most of these people are men who are not bothered anyway. So it's always a problem for women who take taxanes and who take anthracyclines. But yes, there are drugs that don't cause hair loss.
Okay, and another question that's from my side actually. A lot of women fear chemotherapy. They fear it so much they don't come forward for detection and diagnosis.
Yeah, yeah.
What can we do as medical professionals to reduce that fear?
So I think we need to put it in perspective. And I always talk to my patients saying that you've moved into a digital era. Your computers have gone from the primitive desktop and the primitive huge computers to very sophisticated tablets. Surely you must have faith that chemotherapy has also moved along, and we have very sophisticated ways of giving nanoparticle technology, liposomal technology. And our antiemetics are so good that we've made it possible. The fact that we are telling you it's a daycare treatment means that your side effects are less and you're not going to go home and collapse. That's one thing I tell them. Very often, I will introduce them to somebody who's finished chemotherapy. That makes a big difference to them. And, if it's someone who's a whole lot younger and who's gone through treatment and is doing really well, or a whole lot older and has tolerated it very well, it makes a big psychological impact. The third thing is get them into a support group as soon as possible. Once they share experiences and find they're not alone taking chemotherapy, they're much more amenable to continuing with the treatment. So these are a few things you can do to kind of encourage them to take it.
Thank you, ma'am. That was really nice. And I hope the audience also loved the talk as much as I did.
Thank you.
Thank you. So now let's move on to the next speaker. Our next speaker is Dr. Sujata Rajput. Dr. Sujata is a consultant OB-GYNEC at Ruby Hall Clinic, Vanori. She's done her MBBS and DNB along with a fellowship in laparoscopy from Germany. She's also specialized in infertility treatment. She's a postgraduate teacher for CPS and DNB. And her areas of special interest are high-risk obstetrics, gynec oncology, and infertility. She has to her credit multiple national and international publications. I request Dr. Sujata Rajput to share her expertise with us.
Good afternoon, ma'am. Good afternoon, everybody. At the outset, I would like to thank Anupama Mane ma'am, Varsha Hardas ma'am, to have given me the opportunity to speak about the role of gynecologist in management of breast cancer patients. Breast cancer, as we all know, is the most common malignancy in the women. The incidence increases with age. Majority of them are diagnosed after menopause, but 15 to 25% of cases are premenopausal at the time of diagnosis. 7% of them are below the age of 40. Therefore, a considerable amount of young women are diagnosed with breast cancer during their reproductive life. Now, as a gynecologist, I would like to bring a few topics here, such as breast cancer in pregnancy, the role of a gynecologist in fertility preservation when the patient is diagnosed in the reproductive age group, the post-treatment amenorrhea, and hormone replacement therapy. The incidence of breast cancer in pregnancy is as high as 1 in 3,000 pregnancies. It is the second most common malignancy in association with pregnancy. Survival rates equivalent to non-pregnant patients. The presentation usually is like a painless mass, 60% concurrent and 60% concurrent lymph node involvement. The investigations that we advise usually in all the women are the same as, in the pregnant women are the same as the routine women. So this includes sonomammography and mammography. There are a few doubts about mammography, but mammography can definitely be done in pregnancy with proper abdominal shielding. With biopsy, a needle biopsy or a true cut biopsy is to be done and is not to be delayed until after delivery. The treatment in this pregnancy with breast cancer is to be individualized. The considerations here include patient's age and desire to continue pregnancy. Interruption of pregnancy does not alter the prognosis for patients with potentially curable disease. Chemotherapy, first trimester, is lethal or teratogenic. The generalized recommendations for treatment in pregnancy include, in the first and the second trimester, a modified radical mastectomy with or without a sentinel node biopsy, the role of which is controversial. The use of blue dye is contraindicated, and the safety of radiocolite is not well documented. Adjuvant chemotherapy can be given after the first trimester, usually, but it is not given outside clinical trials. If a chemotherapy is given in the first trimester, the chances of fetal malformations are as high as 20%, whereas in the second and third trimester, these fetal malformations drop to 1.5%. Tamoxifen is a class D drug, and it is not to be used in pregnancy and in lactation. If there is a localized tumor in the third trimester, a breast conservation surgery, radiation can be delayed until after delivery, or a patient can be treated with modified radical mastectomy. If the fetus is viable, the labor is induced early to avoid any delay in definitive cancer therapy. If the diagnosis happens during lactation, we suppress the lactation and proceed with definitive management. If the patient in pregnancy is diagnosed with an advanced incurable cancer, palliative therapy, the decision regarding the continuation of pregnancy is based on the therapy that is necessary for the patient and the desires of the mother and the family. Counseling regarding future childbearing is very important. Theoretically, only women with estrogen receptor positive and progesterone receptor positive tumors would be affected deleteriously by subsequent pregnancy. The recurrences most frequently happen within the next 2 to 3 years after diagnosis. So, averagely, a 3-year wait period before planning the subsequent pregnancy is advised. As we all are aware that more women in the reproductive age group are peak diagnosed with breast cancer, so has the need arisen to preserve their fertility, menstrual, and sexual function. Within this group, that is the younger age group, the reproductive age group, most cancers require cytotoxic chemotherapy and or hormone therapy, which further decreases in the patient's reproductive function, along with the age-related decline in their fertility. The efficacy of these treatments, among other factors, has led to a high 5-year survival rate, which results in an increasing number of young women who survive breast cancer before having fulfilled their reproductive wishes, especially considering the current trend to delay pregnancy until the late 30s or early 40s, usually in the developed countries. In addition to chemotherapy, about 2/3 of these patients under the age of 40 generally present with a hormone receptor positive tumor and will therefore receive a 10-year treatment with tamoxifen or with or without a GnRH agonist. Recent improvements and the growing research in fertility preservation techniques have made a number of possibilities available for these women. Unfortunately, both the patients and healthcare providers often forget to attend to this issue after diagnosis, where an early referral to a fertility specialist is fundamental in order to achieve the best results and benefit from a wide variety of fertility preservation techniques without compromising the efficacy of their anti-cancer therapy. So, the need of the hour is fertility preservation and reproductive counseling in the younger age group. The factors for selection of fertility preservation techniques are age at the diagnosis of the breast cancer. Younger the age, better is the oocyte quality. As we all know, there is an age-related decline in the quality of the oocytes that we retrieve. By the age of 37, usually 95% of these oocytes that are present at birth undergo apoptosis. And by the age of 40, fecundity rate is 50% compared to that of a 30-year-old woman. And there is a 3-fold higher risk of miscarriage. Ovarian reserve at the time of diagnosis. This is also a very, very important factor in fertility preservation. Antimullerian hormone and the ultrasonographic antral follicle count are the two main markers of the ovarian reserve. Given that the most premenopausal breast cancer patients are older than 35 years, there is a natural baseline fertility impairment because of their age. The cancer condition and the anti-cancer therapies accelerate the decrease in their reproductive function. The cancer-related factors to decline the fertility are the molecular subtype of breast cancer. It determines the need of gonadotoxic therapy. Therefore, these cancer-related factors are very important in deciding what kind of fertility preservation technique are we going to select for the particular patient. The cancer usually causes a decrease in the AMH and inhibin B levels, and it causes an increase in follicular-stimulating hormone. The BRCA mutation carriers, either healthy or already diagnosed with breast cancer, are also capable of achieving pregnancy despite their added difficulties, mainly a higher tumor aggressiveness and a lower ovarian reserve. The treatment-related factors are, upon diagnosis, a referral for a fertility preservation occurs between the primary surgery and the start of adjuvant chemotherapy. So any fertility-related procedure should always be done before the start of the adjuvant chemotherapy because of its gonadotoxic effects. In case of a neoadjuvant therapy, such referral should take place before treatment starts. Not only this provides a very limited time frame, but also presents the risk of tumor growth during follicle stimulation, a particularly delicate matter for patients with ER-positive tumors. The fertility preserving techniques. Once a good ovarian reserve has been predicted, several ARTs can be used. These techniques could be divided into three groups. Techniques that try to reduce the impact of chemotherapy on ovarian function, techniques that are finalized to obtain oocytes or embryos that could be cryopreserved, techniques which try to preserve and freeze ovarian tissue before the beginning of chemotherapy. A wide range of fertility preservation techniques are the ones are ovarian suppression, the oocyte and embryo cryopreservation, immature oocyte retrieval and in vitro maturization, and ovarian tissue cryopreservation. The ovarian suppression, usually it is known that suppressed ovary gives a protection against chemotherapy. Normally, GnRH agonists are used for this purpose. The advantages being it inhibits menses and prevents menorrhagia. The disadvantages here are it requires several weeks before a complete ovarian suppression can be achieved. Thus, the protective effect of these GnRH agonists could only be certified at the end of chemotherapy. So, this is not a so much practiced method for fertility preservation. Obtainment of oocytes prior to the beginning of chemotherapy is a safer option for these patients. Most types of breast cancer are hormone sensitive. Elevated estradiol levels, usually obtained in controlled ovarian hyperstimulation cycles, are the main problem in order to warrant their oncological prognosis. So, several COH protocols have been investigated in order to solve this problem. We all know that tamoxifen is a selective estrogen receptor modulator. It reduces the overall mortality and relapse rates. The fact that this effect has been demonstrated in premenopausal women with estradiol levels, serum levels similar to fertile women, has led to the investigation of protective effect of this drug in breast cancer patients undergoing controlled ovarian hyperstimulation. A recent study has demonstrated that there are no statistical differences in the number of oocytes collected between the patients when tamoxifen is co-administered during COH compared to those patients which did not receive this drug. Aromatase inhibitors are similar to tamoxifen. They decrease the E2 levels in the breast cancer postmenopausal patients, being effective in reducing the breast cancer mortality and relapse. This ability to keep the estradiol levels in a low range have also led to the investigation of their role in keeping low E2 levels in breast cancer patients undergoing COH. So, letrozole is considered to be safe. Possibility of having 2 controlled ovarian hyperstimulation cycles before starting chemotherapy, thus getting more oocytes in these patients. The disadvantage of this technique is that this treatment could lead to achievement of higher rates of immature oocytes. Usually for ovulation trigger, a human chorionic gonadotropin is preferred. But in patients with cancers, GnRH agonists are better to trigger oocyte ripening, as they lower the a lower hyperstimulation syndrome. And the advantage here is the higher number of oocytes are retrieved along with the higher maturation and fertilization rates. The immature oocyte retrieval and in vitro maturation is a newer technique. The advantages here are it can be done in unstimulated ovaries. It is faster than starting a controlled ovarian hyperstimulation. The E2 levels are always in the low range. The cost is lower as the need for medications to obtain the oocytes are not used. Either way, it seems that 50% of immature oocytes retrieved could be matured in order to be fertilized. Ovarian tissue cryopreservation. Finally, cryopreservation of the ovarian tissue has been investigated. This technique consists on the surgical retrieval of ovarian tissue, including whole ovarian cortical tissue. So in this, the entire ovarian cortical tissue is to be preserved. Once this ovarian tissue is obtained, it can either be used for post-chemotherapy transplantation or for follicle aspiration in order to get mature or immature oocytes that could be used for one of the previously described techniques. Once experimental, this technique has nowadays been demonstrated to be useful as reports of the achievement of several pregnancies after ovarian transplantation is being published. This particular technique should be avoided in BRCA mutation carriers in which it could end up with the development of ovarian cancer. Now, along with the fertility preservation techniques, after the chemotherapy, most of these patients also suffer from something which is very important in a woman's life, that is amenorrhea. Amenorrhea in this women is usually when the menses do not resume within the next 6 months of the chemotherapy, when these patients are not pregnant or not using any hormonal contraceptions. This amenorrhea has been shown to represent menstrual dysfunction, early menopause, and sexual dysfunction. The consequences of this amenorrhea are loss of fertility and physiologic symptoms such as night sweats, hot flashes, vaginal dryness, and weight gain, along with a premature ovarian failure. The risk factors for getting the amenorrhea post-chemotherapy treatment are age, older at diagnosis, the chemotherapy, mostly the alkylating agents, nulligravidity, and radiation. As per the age, more than 40 years, five-fold higher risk of chemo-induced amenorrhea than younger women. This is due to the reduced quantity of ovarian follicles and subsequent accelerated follicular atresia. At an age less than 30, the chemo-induced amenorrhea, the rate is between 15 to 40%. So, younger the age, shorter is the amenorrhea. It must also be noted that despite its wide use as markers of reproductive function, neither amenorrhea is a synonym of infertility nor resumption of menstrual cycles is a sign of fertility. Chemotherapeutics induce ovarian toxicity by damaging the primordial oocytes, causing significant vascular injury, causing focal cortical fibrosis, and segmental collagen deposition. Out of all the chemotherapeutic agents, cyclophosphamide is supposed to be the most gonadotoxic. It has an action on the ovaries within 48 hours after its administration. The effect on reproductive lifespan can be equally strong. One cycle can, at a standard dose, can accelerate ovarian aging by up to 3 years in the terms of reproductive function, while a whole regimen administered over 12 to 16 weeks can increase the aging by up to 10 years. This means that a woman who starts at 30 will have the equivalent ovarian age of 40 by the end of the treatment. So, there are a few strategies so that we reduce the follicular damage by alteration in the chemotherapeutic regimens and thus reduce the gonadotoxicity. Resumption of menses in breast cancer survivors takes longer than 1 year compared with the lymphoma and other pelvic cancers. The average time for resumption of menses is usually 2 years. However, once resumed, the older women are more likely to have irregular cycles. Recent literature suggests that menstrual function patterns are linked to bone fracture and osteoporosis, cardiovascular diseases, and mortality, breast and ovarian cancers, diabetes mellitus, and decreased lung function. On the other hand, amenorrhea has been linked to a reduction of recurrence and to an improved survival, as it can be the reflection of a permanent ovarian dysfunction. early resumption of menses, poor prognosis, and a shorter disease-free survival. Amenorrhea thus serves as a marker of chemotherapy efficacy. What are the interventions for the symptom management of amenorrhea? The main aim here is to ameliorate the menopausal symptoms and improve the quality of life with pharmacological, psychoeducational, and behavioral interventions. The pharmacological. Now, the very well talked about and the most talked about is the hormone replacement therapy. The systemic treatment with exogenous hormones is generally contraindicated. Localized estrogen therapeutic options, such as vaginal rings, tablets, and creams, can be individualized. A well-designed clinical trial, that is the HABIT study, found that breast cancer survivors taking post-chemotherapy hormone treatment were much more likely to develop a new or recurrent breast cancer than women who were not taking these drugs. The HABIT study in 1990 was two randomized clinical trials started in Scandinavia, addressing whether hormone replacement therapy is safe for women with previous breast cancers. All analyses were done according to the intentions to treat. Until September 2003, 434 women were randomized. 345 had at least one follow-up report. After a median follow-up of 2.1 years, 26 women in the HRT group and 7 in the non-HRT group had a new breast cancer event. All women with an event in the HRT group and 2 of those in the non-HRT group were exposed to HRT, and most women had their event when on treatment. It was decided that these findings indicate an unacceptable risk for women exposed to HRT in the HABITS trial, and the trial was terminated on 17 December 2003. Although HRT is traditionally viewed as a contraindication in women with a history of breast cancer, more women are willing to receive HRT for symptom relief. A potential scheme for possible HRT use in selected breast cancer survivors with severe climacteric symptoms is suggested. The duration of HRT use is debatable because there is insufficient evidence at present. However, the available data suggests that 3-year and possibly 5-year HRT use can be safe. In summary, while HRT cannot currently be recommended as first-line therapy, it may still be of benefit in the management of selected early-stage breast cancer survivors with refractory climacteric symptoms after a well-informed decision and an individualized risk-benefit discussion. So was the need for the non-hormonal medications. These diminish both the occurrence and the intensity of hot flashes. Certain antidepressant drugs such as venlafaxine, escitalopram, paroxetine, and other medications like gabapentin, clonidine, and oxybutynin are used. Vitamin E phytoestrogens and black cohosh have no strong evidence in reduction of hot flashes. Endocrine treatment is a very well-known part of the breast cancer treatment. It helps lower the risk of developing breast cancer. For women who have been treated with breast-conserving surgery for ductal carcinoma in situ, that is a hormone receptor positive, taking tamoxifen for 5 years, lowers the chance of BCIs coming back. It also lowers the chance of getting an invasive breast cancer in both the breasts. Caristin is another SERM that works in a similar way, but it is used less often and is only approved to treat metastatic breast cancer in postmenopausal women. It is not likely to work if tamoxifen has already been used and has stopped working. The disadvantage of these medications, again, leads to hot flashes and the vaginal dryness. So, along with this vaginal dryness comes the sexual dysfunction. The vaginal dryness and dyspareunia are the main drivers of sexual dysfunction. There is loss of libido, which causes anxiety, depression, body image concerns, and fatigue. It is important to concern that sexual problems are complex, often interrelated, and if ignored or untreated, can lead to long-term sexual health issues. So, to improve the sexuality and the sexual dysfunction in these women, individual and couple counseling are of utmost importance. The vaginal dryness, which happens, and the discomfort, it can be bothersome in the menopausal symptoms for some women. Some non-hormonal treatments, including vaginal moisturizers, lubricants, and gels, are available to treat vaginal dryness. If these aren't helpful, low-dose hormonal inserts, tablets, or creams that are inserted directly into the vagina might be helpful. Devices that use lasers or other forms of energy to rejuvenate the vaginal tissues are now being studied as well. It is crucial to advise women to maintain sexual activity, to maintain blood flow to the vagina, to prevent atrophy, and thus improve the vaginal dryness and the hot flushes. Also, pelvic floor strengthening and vaginal dilatation are being suggested. So the interventions to consider for menopausal symptom management include the hormonal and the non-hormonal medications. Along with them, the behavioral strategies and interventions such as exercise, yoga, acupuncture, cold packs, dressings in layers, and a psychoeducation consisting of cognitive behavioral therapy, individual or couple counseling is of utmost importance. This helps in improving the quality of life in both the short and the long term. The cognitive behavioral therapy, the physical activity, combination of the two can help improve menopausal symptoms as well as quality of life outcomes, including sexuality, urinary problems, and physical functioning in the women with premature menopause. The cognitive behavior therapy is helpful with sleep, emotional, and cognitive issues. Interventions teaching relaxation strategies have also demonstrated some effectiveness in improving vasomotor symptoms in breast cancer survivors. Exercise helps women of all ages, improving symptoms of anxiety, depression, and fatigue. It is also beneficial on the effect on the bone health. It prevents any further weight gain. So, the take home message here would be the cancer mortality rates have recently been declining across all age groups, which warrants further attention to the health and quality of life of survivors, as there is an increase in the 5-year survival rate and the breast cancer being diagnosed at an earlier age. It is the responsibility of the healthcare team to explain prognosis, treatment options, and potential toxicities, adverse effects of the chemotherapy, radiotherapy, and endocrine treatment, and educate about fertility issues and refer them early to appropriate specialists as requested. Thank you.
Thank you, Dr. Sujata. That was really nice, a very comprehensive talk about all the gynec aspects which are related to breast cancer treatment. And I really believe it is all a multidisciplinary, approach by which
Yes,
we can actually give the best patient care.
yes,
Because there are so many things that we are not aware about your field, you are not aware about our field, and similarly with other fields also. So we really have to talk more to each other about each patient and then
yes,
give them the best.
yes.
So thank you so much for your talk. And I just have one question. What about oral contraceptive pills? Do they increase the risk of breast cancer? And if young women come asking for contraception advice who have some family history of breast cancers or something, I mean, will you advise them, or what do you do?
Yes, ma'am. Definitely, the oral contraceptive pills they have shown to increase the risk of breast cancer in the younger women, specifically in the ones who have BRCA mutations. So we advise them to go ahead with some other mechanism for contraception. Some other devices like a barrier or a copper T is a more preferable method for contraception in these younger women.
And are there any OC pills which are safe, like low dose or something? If you really
There
have
are
to,
low dose pills, ma'am. Nowadays, there are a lot of pills that are available with a molecule size as small as 20. So these can be given, but for a limited period of time, usually not more than 2 years. And then evaluation definitely needs to be done after 2 years, and for recurrence or any symptoms need to be checked for.
monitored.
Yes, yes,
Monitored.
yes,
So
yes, yes.
basically, OC pills and HRT as such are not really recommended for
Not
these.
really recommended. Yes, ma'am. Yes.
Okay, fine, great. Thank you so much, Dr. Sujata.
Thank you so much, ma'am. Thank you.
So now let's move on to the next part of our session. Good afternoon. Good afternoon, everybody, once again. And as our conference is going on, I would just like to make a couple of announcements. One is that we are doing a lot of breast cancer screening programs in Pune and the rural areas around for our community women. And we actually seek your support. We are having a fundraiser for breast cancer awareness and support group programs along with keto, and our goal is to raise 5 lakh rupees. This will help to support us for 1 to 1.5 years for arranging all the programs, as well as funding some needy patients who can't afford treatment. So the link is given at the bottom of the page. Please go on it, click it, and I would request you even 100, 200, 500 donation would be of a great help. So please support our initiatives and efforts. Thank you. And I would also like to inform our audience about our breast center. Basically, we have started a breast center which is highly specialized in Ruby Hall Clinic, and it has experts in all fields: breast surgical oncology, medical oncology, and breast radiation oncology, cancer genetic specialist, breast radiologist. And the most important thing is it is an all women team. So the lady who comes for any checkup or any issue is most comfortable dealing with all lady doctors. And the privacy of the patient is taken care of. We have totally secluded setup and all the facilities possible. And these are quite high-end facilities, which you would find in any major Western specialized breast center also. So along with a 3D digital mammography, tomosynthesis, elastography, high resolution sonography, 3T MRI, stereotactic biopsies, vacuum assisted resection biopsy systems. Then in breast surgical oncology, we have all procedures possible, the oncoplastic surgeries, breast reconstructions, and medical oncology, the latest treatment for breast cancers. We have a very good functioning support group which meets every second Saturday of the month, and all our breast cancer patients are given very good support and encouragement through that group. And of course, as I just mentioned, we have a lot of cancer screening programs going on in and around Pune. So we are trying to make an effort from our side to improve the breast care amongst women. We would like you all also to collaborate with us in this. If you need any help with any kind of patient for with breast diseases, any problems, any issues you would like to discuss with any of us, Dr. Varsha Hardas, Dr. Shona Nag, Dr. Mansi Munshi, myself, or anybody else in the team, you are most welcome to get in touch with any of us, and we would be very happy to extend our support to anyone. So thank you very much for that. And can you play the little video, please? Hi. So now we'll move on to the next session. And that is a very interesting panel discussion, actually. So, on the occasion of International Women's Day, basically, we wanted to reach out to more and more women and initiate a program on their own health and cancer awareness and spread the world around. Let health be the key word on this International Women's Day. So the next panel discussion focuses entirely on this topic, and I invite Dr. Varsha Hardas to lead us into the topic and have a very interactive and interesting discussion. Dr. Varsha Hardas, please.
Thank you, Anupama. I think we've had a wonderful morning just discussing about various aspects of breast cancer, more medical treatment and imaging and treatment. But I think when we look at so much of breast cancer disease and we have treated the patient, actually our role as doctors should not end there, because all these women have a lot of other issues and they require a lot of support and a lot of understanding to how to go about all these the phases after the treatment of cancer is complete. So I think even discussing all these points is very, very important. Understanding these points, understanding the needs, sharing of all the various experiences that they go through is very important. And that's why, as you said, that a support group is also equally important. But also a little bit of understanding for the doctors is equally important. How to deal with that, how to extend that support through various people is equally important. So I think we have to educate our breast cancer patients about how to lead their probably future life after they have treated with the completed their treatment. So we know that on this Women's Day, we have kept this symposium and we have made a good mix of medical as well as non-medical discussions. So we've finished almost entirely the medical discussions and we are moving to a little bit of non-medical discussion as well. And on this Women's Day, we have a lot of people now logging in who are non-doctors, and basically this is also for them. So I would like to say that every woman is special, every woman is beautiful. Sometimes she's a daughter, she's a sister, she is a partner, she's a mother. And in every way, I think she contributes a lot to the family. And her health is equally important. And understanding her, giving her the support when it's needed is also equally very, very important. And I would say that we don't want to just celebrate these women, these all beautiful, special women on just this day or on Women's Day, but I think all throughout. And just as a special acknowledgement to all the women who are fighters and who are challengers and they're always taking up challenges. I think we are going to have a very good panel discussion, because on my panel, I have some very exemplary and very accomplished, inspirational panel members here. And I'm looking forward to invite all of them and have discussion with them. It'll be a question answer or more of story sharing kind of session. And let me start with introducing each one of them first, and then I think we will move ahead and take up the questions. So today I have with me Dr. Manisha Doifude, who is a clinical genetist who's been practicing in the PMC area for the last 15 years. She is an editor for Spandan, and not only that, but she's a marathon runner and she's completed multiple half and full marathons in the past years. She's a corporate speaker too. But her story is what I think I would like her to share, but I would just like to introduce that she's a cancer survivor. Unfortunately, she had cancer detected in 2015. And I think that was the point when her life changed, or she decided to change things for herself. And it's really inspirational. And we would love to hear it from her, that how did she go ahead and, do the journey after the detection of cancer. So welcome, Dr. Manisha Doifude.
Thank you.
My second panelist today is a very lovely, young, energetic Miss Kritika Shukla, who comes from a very conservative background. And I think it's a brilliant example. When I met her last, I was so impressed by her. She's done her master's from Mumbai University. She's majored in psychology, done her MBA. And she did her yoga training way back in those days when her family was so conservative and she had to do her yoga in saris. But nonetheless, nothing stopped her from that. And she completed her yoga training program from various academies and institutes and universities. Also did it from Vidya Dham in Nasik. And now is a qualified yoga teacher. And for her, I think yoga is her life. Yoga is her energy. And I would love to invite her here today on this panel discussion. And welcome, Kritika. Welcome for this panel. I hope you're here logged in.
Yes.
Okay, lovely, lovely
Okay.
to
Thank
see
you. Thank you,
Yeah,
Varsha,
lovely,
and
lovely
for
to
such
see
a
you.
lovely introduction. I also didn't know. I
So
had forgotten.
you can't
You made
forget.
me
You shouldn't let
remember
yourself
my old
forget.
days.
Yes, yeah. So my
Okay.
third speaker and my third panelist today is Sonia Agarwal Konjeti, and I think many of us know her, and there is no need for really any introduction, formal introduction. But for people who don't know her, she is a lady who has founded India's largest women group in our city, and that is called as Pula. She started in 2015 when she had only just about 300 members, and now it has crossed more than 2.5 lakh members, and it's still growing. It was her brainchild to create a female family, to connect with each other mutually, support each other, make them financially independent. And her idea was that women have to break their silence. They have to speak for themselves. They have to show their work. They have to empower themselves and overcome the challenges of life. And that needed some platform and some support. And I think beautifully she has given them that platform, and it's been very, very successful. She herself is a strong believer of karma, and I think she has also received many, many awards for the work that she has done. And I'm very happy to invite her here on the panel today. So welcome, Sonia. I hope you are here. Are you logged in?
Yes, thank you so much, Dr. Darshan, for seeing me. And hello, everyone. It's a lovely morning to see all of you all and talk with and hear everyone and learn so much more from all of you. Thank you so much.
So my other three speakers are doctors, and other panelists are doctors. I would like to introduce Dr. Rajput, who is a gynecologist and has very keen interest, and her specialty is infertility and oncology, and she's a practicing gynecologist at Ruby Hall Clinic at Vanavi. So welcome, Dr. Sujata. I hope you're here, Dr. Sujata.
Yes.
Yes.
Good
hi.
afternoon.
Hi, good afternoon. And
Hi.
my next speaker is young, dynamic Dr. Mansi, whom we have. Hello,
Hello, hi.
Yeah. Hi, Mansi, welcome to this
Hi,
platform.
thank
And
you.
I'm sure genetics is such a vague area. People know about genes and mutations, hereditary, familial, all those words, but they
Yes.
really don't. I don't think they understand a lot. So I'm happy that you're here on the panel and you will answer some questions and clarify their doubts.
Sure,
So
absolutely.
welcome to this panel. And
Thank you.
my last panelist is none other than my close friend and colleague and very, very accomplished breast oncosurgeon, Dr. Anupama Mane, who's been practicing in the city of Pune. And I think we are extremely lucky to have here with us in Pune. Welcome, Dr. Anupama.
Thank you, ma'am.
Yeah, hi. So I think let us start with our discussion and let us say Happy Women's Day to everybody. And I would like to know why. My question would be first to Dr. Anupama. Why do you think we have the need to educate our women about breast cancer? Like, do you think that they are lacking the, in your experience, in your practice, do you think that these all our women who are there probably don't know much about breast cancer, even if in spite of having symptoms, we have seen that they have lumps, but they don't come forward, they don't come ahead. So what are your like about
So,
general women's health
general.
and how they should come
So
forward?
overall, see, there are two reasons for this lack of awareness amongst women. One, of course, is their own perception, their own level of education, and their perception about their health, which in India actually is very low. Very less importance is given to maintain the women's health in the family. The woman always is concerned about her husband or children's health. So that is first, they kind of tend to ignore it, and that is because of their own upbringing, the cultural factors, the social factors. And secondly, I feel it is because of the government also. The Indian government, and especially in our country, they are focused more on infectious diseases, on malaria, tuberculosis, and all those other diseases, which are major causes of concern. I mean, I won't say they aren't, they are. But cancer is also equal public health concern. It is a major
Correct.
area, and leading to mortality, high death rates. So I feel the government also should focus more on it. And the more advertisements or the more talk there is in the media
Awareness.
about this, yeah, the more people will know. So
Yeah.
current level of awareness, I feel, is very, very low, but it
Yeah.
has to increase.
I think also, let's not scare anybody, but we will talk about it later. But women, probably general public, wouldn't know what comes along with the diagnosis of breast cancer. So it's a long journey. They have to know about why it is important to probably go ahead and seek some consultation. So we will discuss that through our talk. Let me move on to my next question to um, Sonia. Sonia, you are the head of such a huge organization and you are dealing with women every day. You are probably also interacting with them all the time and you know about their issues, their problems. So what is it that you would like to highlight here? Like, why is there such hesitancy in probably seeking a medical advice when it is necessary?
Um, Two things, ma'am. One I feel is every woman, whenever she's trying to keep her family happy and or her running her business or doing her job, she ignores her health. And I think that is the most important that every woman forgets, which is the most priority, which should be the most priority on her list, is to take care of her health. And to fulfill this entire circle of life, and बच्चे का डब्बा बनाना है, पति का डब्बा पैक करना है, फ्रॉम बच्ची की पढ़ाई लेनी है, घर साफ करना है, मेड आई कि नहीं, सब कुछ प्लान करते करते they never remove time for themselves. And I feel that is what we need to educate more, or inspire or motivate the ladies more to take care of their health. And then the different kind of categories of of course taking care of getting your breast cancer checkups done or getting a health checkup done yearly once, all those different kind of blood checkups etc is very mandatory, which many of them ignore. So even on our platform, we have a lot of doctors, we have a lot of experts, we have these different days where a lot of the experts talk about it and they try to spread awareness. And with that we try to educate or motivate many people to at least start living their life for themselves and become healthy. And I think there's nothing better than that today.
Yeah, but in my experience, to be very, very honest, whenever we have tried to conduct such things, the medical part of things, and try and give talks to the women, or encourage them to come and participate for such things, to just to let them know about it, they always shy off. They say, no, 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 why am I going to go and attend this? It is not necessary. Why should I do it? Unless somebody who has gone through a particular problem, they do not to even come forward to educate themselves about this awareness. They feel कि नहीं नहीं ये जरूरत नहीं है. What do you say about it? Why is this so?
in fact, that was, I wanted to put up a question to the panel over here from my end, that I see so many awareness camps. I see so many free checkup camps for ladies. Different Indian medical associations are organizing, different hospitals are organizing, and they're trying to do their best for women, ki aap aao, just try to, they want to spread awareness, they want to get checkups done. But I don't know, women, many of them just don't want to get out of their comfort zone. Are they scared, or don't they have correct knowledge? Even we are, at times lacking with that kind of understanding as what do women want? What do they want? Why aren't they moving out of their seat? And what more can be done? I don't know if any doctors here can answer that.
Yeah, no, but you can see that you have a non-medical thing, you have a exhibition, you have some other platforms like, कि आज यहाँ पर exhibition लगा है, वहाँ पर कल कुछ cooking हो रहा है. All the women will rush to those places. All the women will rush and, want to see everything. But one thing what is not happening is, especially whenever there is health related issues which we are going to talk about, they are just shying off. So I think we should together create some platforms or way where we can pull them into this, just to educate them, so in case they are faced with such issues, they should not shy off and come and attend to a doctor. So also at this point I would like to ask Mansi, is there anything what you would like to say about the genetic part or the hereditary part? Because, women know these words, but still there are a lot of women whose probably mothers or aunts or masis have had breast cancer. They have a history, they know about it, grandmothers have had, but they still never care to come ahead and, talk about it to the doctors. So what is your opinion about it? What would you like to tell the women out there who are listening to us, that why it is important, who should come forward, or at least even if they are having no symptoms, so they are waiting, when jab dard hoga ya jab kuch lagega to jayenge. It should not be that way. Would you like to say? Mansi,
yes, am I audible now?
Yeah.
So I strongly believe that awareness is very, very important amongst women. That if there is a strong family history of cancers in the family, it may not only be breast cancer, it may be any other kind of cancers as well. Sometimes in the male members in the family, it may be prostate cancer, ovarian cancer, and other women. They must bring it to the notice of their doctors, because these days there are some tests available by which we can understand whether this is just a coincidence, or is there a hereditary mutation in the family because of which the individual may be at a higher risk of developing
but does
cancer.
this sound very complicated for everybody? Now they have questions like, if my mom has had a cancer, am I going to have a cancer? Or if my aunt has had a cancer, why should I have a cancer? Because she's my aunt or she's my masi.
Yes. So the answer to that is, the answer to that is that, cancer these days has become very common, and there are many reasons for cancer. So one must not immediately jump to conclusions that if there is a family history of cancer, it will happen to them as well. That is why it's very important to come up to your oncologists and specialists and ask the important questions. The steps followed are basically, first, a genetic counseling is done just to understand that is the history significant or not. Just because somebody has one aunt or one relative with cancer doesn't necessarily mean that they will also have risks. So we evaluate every individual separately, and if it is significant, then blood tests can be done, which are very simple to determine.
We can say that women who are probably have suffered from breast cancer, or whose grandmothers have suffered from breast, do they or will they play a role in encouraging or educating their daughters and granddaughters about this, that whether they want to have tests, whether they should go ahead and do the testing?
Absolutely. I'm just getting an echo in the background, so I'll just wait for
Yeah.
that to end. Yeah. I feel exactly. So yeah, that is why this program that we're doing, and getting women aware and educated. There are a lot of women listening to us right now who are survivors. They have gone through it themselves. Almost everybody knows somebody who has, in their family or friend circle who has suffered from breast cancer. It is that common these days. But I don't want to put the fear in the mind of people that any cancer is,
Exactly.
something to worry about. So for that reason, being educated is very important, and just coming out with the questions, asking your doctor, undergoing a genetic counseling to get the right information. Because, like I always say that every genetic counseling need not end up in a test. So very
Sure.
often we have women who come up with the family history who they undergo the counseling, and we feel that nothing is necessary further. Their risk is just like any normal person, and that also plays an important role in elevating the anxiety that may be there
So at the same
sometimes.
time, I would
Yeah.
also like to ask you that does that mean that people whose parent, whose mother or whose grandmother or aunt have not had a cancer, are they not at risk of having cancer?
Each and every woman is at risk of getting breast cancer. That is known as a baseline risk, and that is why after the age of about 40-45, women have to get the screenings done, which I'm sure you will talk about
We
in
will
today's
talk about that.
sessions.
Yes.
But there are certain women who need something more. Okay, so all women need to be aware. Breast self examination should be done, and breast awareness has to be there for
Yeah. So
all
with
girls
this,
and
I think
all
I will
women.
move to Dr. Sujata to
Yes.
ask her that
Yes.
when the ladies are visiting for various other reasons, gynecologist is the first stop for every woman. Like, they generally don't hesitate to go to a gynecologist. So, Sujata, tell me your experience about like the women who are having other problems come to you. Do you really talk to them about having their test done?
Yes.
Or
Yes, ma'am. Absolutely. Mostly the patients who come during the health checks, now when we ask them about any cancer related history, the first and foremost thing when we ask them about anything, any symptoms, is the fear and the denial. They usually are in the fear कि कुछ निकल ना जाए, and if there is anything, then they are in the denial. During the routine examination, routine test, we ask the patient to do a routine breast examination, a self breast examination that is of utmost importance, so that it can be detected at the earliest. Most of the patients are the ones who ignore their symptoms. So education of these patients regarding the symptoms is very important. Any kind of lumps, any kind of discharge, their family history, all these factors
One
play a
thing,
very important role. And this education during each and every visit with a gynecologist is important.
so I would here like to say that to all the women who are listening to us, that if they are shy of going to the other doctors, but they are very comfortable with their gynecologist, so at least they should speak to them, talk to them about their concerns, and so that at least the gynecologist can guide them correctly to as to whether anything has to be done or whether everything is okay. You can examine them and tell them and reassure them if everything is fine, and if there are tests needed, which you can advise. So I am sure that they will probably trust you more on that. So
Yes.
yeah, so to all the women who are listening to us, that it's the message what we are trying to say here is that please talk, please come ahead and discuss. There is no harm in discussing. The very fear or the fear of what, like if I say something to her, she's going to advise me a whole lot of list of investigations to be done, which I don't want to do. I think that is also one of the major
Yes.
things stops them from trying to speak about
Yes.
themselves. With this, I would here like to talk to Manisha. Manisha, we would like to know your story. Like, what was your life before you got diagnosed? Did you ever do your test? How did you come across this? How did you move ahead? So, in brief, if you would like to share your story, because you yourself are a medical person, you yourself are a a practicing medical person, but even then you probably must have faced some issues before getting diagnosed. So we would like to hear your story from you. And I want you to also address to our all the listeners about what is the right way to go, what is a good way and a proper way to deal with this. So over to you,
Okay.
Manisha.
Hi. Yeah, so uh, the how I diagnosed the breast cancer. I had a very small lump actually. Now I have been used to doing breast self-examination from the
Wonderful.
age of 35. Uh, so I have always been very conscious about my health. I have also been doing. I used to play right from school. I used to dance. I used to play during school time. So I've always enjoyed fitness activities. And after the birth of my two children, and from the age of 35, I started doing self breast examination. I used to do my blood tests and sonography, pap smear, all
So
pap
here I would
smear.
just like to ask that did that help? Did doing
Yeah.
self-breast examination
So, yes.
help?
So that's how I actually diagnosed the lump, because
So
since
you
I
are
was doing self breast examination, I knew how the breast tissue would feel normally. And the day it was actually it was like late evening, and I found that there was, something was not right when I was doing the self breast examination. And it was a very small lump, of course. I wasn't sure, but it definitely felt different. Now, why it felt different was because I was used to doing self breast examination, so I knew how the breast tissue would feel on, all the times that I was doing the examination. And and that's how I felt there's something which is wrong here, and it seems lumpy, it is not normal, and this needs to be addressed. So that's how I the next day immediately I contacted the doctor. He advised me to get an ultrasound and a mammogram done, basically. So mammogram is an X-ray test which is done to actually diagnose any breast conditions. So after he examined me, he was suspicious as it is as soon as he examined me. But of course, you cannot be sure until you have some investigations. So once he examined me, and then I got these tests done, then things just moved ahead. And
So was it
unfortunately,
very shocking to
yeah,
know that?
unfortunately, the diagnosis was cancer. To tell you very frankly, my family and even me, we were least expecting it. Nobody expects a diagnosis of cancer, as where you just have something which seems different in your breast and then it's directly a cancer. Actually, that was the first shock. Let me put it that way. I'll tell you the next shock later. So we were also very surprised and completely, I mean, shocked that this seemed suspiciously like cancer. So the diagnosis on the those ultrasound and the X-ray findings were very, very suggestive that it seems to be cancerous. So I had to undergo a biopsy. That's procedure. So that is what was done for me also. And of course, the diagnosis was established. So I had to immediately contact the oncologist. And So I had a very nice oncologist. So what happens is, with women, whatever diagnosis we undergo, it's not a diagnosis for yourself, it's a diagnosis for your family. My kids were very young at that time. They were 9 and 7. So the first thing that always comes to your mind is, oh my God, now how are we going to all handle this together as a family? Because you're so used to looking after everybody, handling your home, handling your career, everything. So it took me a lot of time to digest it, and we as a family were just completely finished. So it was really hard on us. I mean, though we are all doctors in the family, my husband is also a doctor, and we have a lot of doctors in the family, but yet it was hard for us to digest it. And so the next thing, once the oncologist explained, what procedure would be the the next thing which would be done? The oncosurgeon, I'm sorry. What would be?
So let me
Yeah.
put it this way, that it's 5 years now,
Yes.
more than 5 years, and you're
Yes.
doing extremely well.
Yes.
You're doing extremely well. So I'm
I'm
sure
doing
you have
extremely well. And
yourself.
I'm 5 years cancer free. Yes.
Yeah. So I'm sure you yourself have worked very hard on making things right. So nothing
Yes.
kept you from, getting shattered and disturbed and, go back into some shell. You have
Yes.
come out gloriously. And I would like to actually listen to that story. And we would want you to that. How did you change that aspect, that you did not sit back and said, oh my God, I'm a sick patient. I'm a cancer survivor. I can't do anything. You have not done that. You
Yeah.
have in fact done much better in the post-cancer treatment phase than what probably you have done in the prior phase of your life. And we would like to really listen to that part. That's when I understand you started your, completely concentrating on your health issues, your diet, and you are a marathon runner. And that
Yes.
started much later in your life. You have completed so many marathons. So your
Yes.
example is to suggest that nothing can stop you.
Yes.
No diagnosis, no treatment blocks can stop you from achieving, if you have to achieve anything, if you have decided. They can be in fact a very good turning point. You come out of your slumber and you wake up, and you don't keep doing your old routine, like you are the only person in the house working for everybody. In fact, you have set an example not only for your family but everyone who knows you, that women are fighters, women are courageous, and women are winners. And that is what we are proud about. And let us hear that story, that what did you change? You finished your completed your treatment, but you did not sit back sulking for yourself.
Yes. So during my treatment, so once the surgery and all was done, I was advised chemo and radiotherapy both. Now, because I was always in fitness, it used to bother me after my surgery that, I was just sitting around and not doing anything. So once the chemotherapy session started, my husband and I started doing light exercises at home. I've been running marathons since before my diagnosis also. So after the surgery was done, I attempted a few light runs, and I found that I was able to handle it. So right from the second cycle of chemotherapy, I started doing running also. In fact, the running helped me so much because it releases endorphins, happy hormones. So I used to feel so energized, so fantastic. I never stopped working in my clinic. I had to take the mandatory 1 week of rest after surgery. 10 days later, I was back to my clinic. And I'd cut down my clinic hours, of course. Because I'm a single clinician, I was working alone in my clinic. So at that time, I approached one of my colleagues to take over my patients, in the time that if I have to go for therapy or whatever. Now that led to a very beautiful partnership. And the year after I finished my radiotherapy and chemotherapy, I established a genetic laboratory in my clinic premises itself. The other thing that I also did was throughout my chemo and radiotherapy, I worked and I continued doing marathons. The other thing that I also did was, one thing that I wanted to change and had been working towards was changing my diet pattern. So I moved a lot towards, eating for the entire family a lot of natural foods, like where there is no pesticides and things like that. So I changed a lot of the diet patterns, that the food that was coming into my house. So
And
I
you
did
think that everything has helped you through this? All
Yes,
those
yes,
things have helped you. And I
yes.
think we could have done this even before, like even now all of us can really move into that zone and give some more attention towards the diet and exercise pattern. Isn't that what
There's
you
one
would
thing
advise
that's
to our
very
audience?
important, Varsha, if I may interrupt you for a second. I used to interact with a lot of cancer patients at that time. In fact, my doctor wanted me to talk to a lot of ladies who were going through the same thing that I was going through at that time. And the first thing that I noticed with cancer patients was that the ladies used to feel very sorry for themselves. And
Sure.
when they felt sorry for themselves, they were never inclined to get up get out of their houses and do anything for themselves. That is why, so let alone doing fitness or anything, the first thing that, they would sit back feeling sorry for themselves. Now that is something which is, it's very hard to get out of. It requires a lot of self work. So, that is something that, women need to address, that when such a diagnosis hits you, instead of just sitting back and feeling sorry for yourself, it's better that you face it head on and see how you can get out of it, faster and
Wonderful,
better.
wonderfully. I think it's just that you take up that challenge. You
Yes.
have to take up that challenge, and you know that nothing can stop you from doing this.
Yes.
And I will come back to you in a short while, but you were talking about diet and nutrition, and here we have a very lovely friend, as I said, Kritika, and I wanted to ask Kritika about her story, that uh, you know, what led her to this healthy diet concept, yoga concept. How did she move into that? Kritika, are you around?
Yes.
Yes, Kritika. So we would like to hear some part of from you as well, that how, as a person coming from a very conservative family, how you fought those odds, how you came out and did what you wanted to do, and how it has helped you, and how it would probably help every woman to concentrate on themselves. Not that I'm saying that don't concentrate on your family, of course you do that as well, but you also at the same time do not ignore yourselves. You can do
Yeah.
a lot to, look after your own diet. At the same time, you can look after your family's diet in the same manner, and plus do what you wish to do. And when you do what you wish to do, is going to make you happy.
Certainly. I'm not able to hear you. Varsha, I'm not able to hear you.
Okay, can you hear me now?
Yeah, yeah. Now I can hear you.
Yeah, so what I was
Yes.
trying to tell you is that
Yes.
when you do
I
what you
just
want
didn't
to
hear
do.
the last statement.
Yeah, so I'm just
Last
going to say
sentence.
that when you
Hmm.
do what you want to do, that makes you happy. And when you're happy, you have
Yeah.
more energy to do more things. So
Yeah.
what are your thoughts on that?
So yeah, so there are two actually parts of my this beautiful journey. Okay, one was like, yes, major setback, and till the time yoga term also was not introduced to me. Yes, but I was blessed to have a flexible body, and after that major tragedy happened in my life, I thought actually that what can I do for this sound mind, because I used to forget the words. I used to forget the conversation. I used to feel that I don't have any memory left after the
Why was
tragedy.
that so?
So first thing, I lost my husband in 2001 in road accident when I was 27 years old, and my kid was 2 years old. So the first thing I thought is my mind should be sound, then I will be able to take care of my kid. And first thing got strike is yoga. So I told my in-laws that will they allow me to do something. And I was lucky. Of course, now I have to use the word lucky. Okay, during that time. So I was lucky, and we got some yoga institute very nearby. Of course, then I had to do yoga in sari. But the one thing is, when you think for yourself, or when you think for yourself for to take care of others, that that motivate you to do anything under the odd circumstances. So circumstances, I could have like sat in the house कि साड़ी में नहीं योगा होता, सब हंसेंगे.
Exactly. I don't
Everybody
think
is
many of
wearing.
us would be very comfortable doing yoga in a sari,
Yes, and
but
that
it's just
same
your
thing goes up with
dedication and your
yoga.
desire, strong desire to
Yes.
do that.
So I will come up to like जब भी yoga somebody wants to do it, the first thing they try to find out the odds in their life. I have job, I cannot move, I have wore the Punjabi, so how will I do yoga? I have to change. No, if you want to do yoga, then there will be something possible for you, and you will be able to do it. So you get the access to their other odds, and you actually overcome those odds, right? So then your mind works for the solution, not the problem. So you have to like
Very
feel,
well said.
you have to, so one thing, and second, the diet part. Okay. So Diet part is something, while doing all these things in my that hardship, I felt that I have ignored everything in my life regarding food and diet. I used to eat whatever is left at home. I used to eat whatever I am getting. And after coming to Pune, I started feeling in my knees hurting while climbing down the stairs. And I thought, this is not me. Being a yoga trainer, how can like I cannot even climb down the stairs. I went to the knee specialist and I got to know I should not be sitting down. I am sitting down for hours now. Okay, I should be using Western toilet on all this. So he was right on his part. Okay, considering my knee condition. But then I thought I should do something else also. And then I started focusing on this protein part, vitamin D, B12, or whatever, vitamins, other minerals, important minerals. And I started eating more clean, more nutritious, and yes, it certainly
So,
helped
so,
me to.
so can you tell us how yoga would help all our women to just
Yes.
remain
So
healthy?
now yoga is like I think I should start, right? Or I disturbed you.
No, no, no. You can
I
go ahead.
okay. So how did yoga help me to do all this? Is we always get confused with the term yoga. Whenever I approach a layman or anyone, first thing they use the word is I cannot do, my body is very stiff, I cannot do forward bending, it hurts me, it does this, something like that. Yoga is not about the complex posture. Many a times I've actually mentioned in my those yoga sessions, it's not at all about the complex postures or doing some asanas every day. Yoga is something when you wake up until you like go off to the bed for your night sleep, you have to be consciously thinking about your breath, or you have to be conscious about your breath, what you are doing. So your alignment, your postures, your movements. Okay, if you have sat for many hours in the office space, you become very conscious towards your breath and you understand that I have to do something.
So
So
you mean to
yoga,
say that even focusing on your breath is a part of yoga? Yoga should
uh,
not be exercise for a few minutes. It should be a way of living. You should
yeah,
be
so
thinking
it's a start
all the
point.
time.
It's a start point. When you start understanding the breath, or when you start doing the physical exercise, you understand the breath. So it is like two-way related. Either you do some physical asanas and you understand, okay, I have to take inhale, I have to exhale, and you start understanding your breath. So what I mean is you become more conscious, more aware about your body, about your health, about your fitness, and you start doing something, it gives you results. That is yoga for me. You do
Right.
something, some
So if you
stretches.
have to advise our ladies, friends, and audience who are here, do you think that if they are obese or if they are stiff and if they have some problem, is it that they will not be able to do yoga, or there are some simple asanas that you can demonstrate that this is a start where you can at least start off and get
Yes,
into that mode of yoga, and then probably take it slowly day by day, or week by week ahead.
yes,
Don't force yourself to do something right at the beginning. It's a process. It's a
yes,
process. You will get better at it maybe in within 6 months of time. So don't push yourself. Listen to your body, listen to what is
yes,
acceptable, and then step up, whether it's an exercise of walking or whether it's yoga. So things have to move that way. Even diet, it's not like one time thing. Okay, from tomorrow I'm going to do
yes.
this. So I'll come back to you for the asanas, and I would like to ask Dr. Anupama a few questions regarding Dr. Anupama.
Yeah, I'm here.
I wanted to know, like, yoga we were talking about. I'm going to go back to yoga, but also we were talking about diet, and now there is a lot of talk about Dikshit diet, intermittent fasting, and doing so many things. And everybody thinks that, oh, from tomorrow I'm going to start doing this. So is that correct? How do women, should they understand the metabolism behind it? Should they build it up? How and when should they start? Is it a slow process? Or they should start, okay, 1 month I've done intermittent fasting and this is what I did not get the results. Let's leave this, move on to something else. So what is your take on that? What do you have to say on that?
So, first of all, everybody's body is different, and every person's nutritional needs are also different, actually. For a child, the amount of proteins, vitamins, calcium that the child needs is very different from what an adult person would need, what a woman would need, what a man would need, or what an elderly person would need. So everybody's needs are different according to their age, as well as according to their basal metabolic rate, the BMR that we call. So some people have a very high BMR. That means they metabolize the nutrients very fast. And some have a very low BMR, and that is genetic. That cannot be changed. The BMR cannot be changed, and that is the reason you see that families, obesity runs in families, because this low BMR is kind of inherited amongst the families. So as I said, the nutrition that your body needs depends upon all these factors. And then you have to focus in onto your cultural diet system also. What are you comfortable eating? What your grandparents have been eating, and your parents and you. So a child is introduced to a nutritious diet right from the time he or she is born, actually. And that is the way you grow up, and you kind of, continue with the diet throughout your life. So basically, I would say that good nutrition practices should start with the child itself, the parents giving a healthy child with a good balance of carbohydrates, proteins, minerals, calcium, micronutrients. All these things have to be balanced. There is actually a food pyramid that shows that carbohydrates have to be approximately to the tune of 70%. Proteins have to be at least 1 gram per kg per day, so depending on the weight of the person. And of course, the fats and all also have to be there. So every constituent is actually important in maintaining our bodily functions. We cannot omit one constituent. Like, you have these fads of keto diets where you just totally skip out on the fats and all. No, that is also not right. Don't go on to any drastic diet maneuvers. Never omit one part of a meal totally. First of all, go for it gradually, slowly, make it into a regular habit. Actually, it's said that if you do something continuously for 3 weeks, it gradually becomes a habit. So try and do that slowly, but maintain a healthy diet. And as I said, one thing may not suit the other person. One person may be very acidic in nature, so can't have acidic stuff. So these kind of things
this
you have
happens
to.
like, so if one of our friends has done something, so she'll say, oh, she has done this, she's lost 2 kilos of weight, I'm also going to start that. So that may not apply to all. And
No,
whatever you do, probably you go gradual, and your body has been used to a particular type of food, so don't drastically change it, and eventually move into that zone slowly, cutting off one by one. But of course, a healthy meal, a freshly cooked meal, also women have the habit, let me finish this. So what I would like to say here is that better out than in is what we should follow. That रह गया है तो इसका मतलब नहीं है कि खत्म करना है तो खा लो. You can just leave it and let it be outside, because it is going to harm you more if it is inside you rather than it being outside. So that I think we should follow. Better out than in is also needed to be followed. And also I think Kritika also had some suggestions about diet. So we will get back to her. Kritika, you wanted to say something about the change of diet, your fresh foods, more pesticide-free food. What do you follow?
Yes. So rightly like spoken by Anupama, that everybody is different. So let's talk about like this intermittent fasting or something like that. So hello.
Yes.
So it is not necessary that intermittent, this IF will suit to everyone. So first of all, I need to understand, okay, if I am following something, it should not be, very harsh on me. One, my body should give me good results. And what about the clean eating or pesticides? So of course, we all know that it's not possible completely that we eat pesticide free, but yes, whatever food we are taking, we can have some calculations from morning till evening that how much green has gone in my body. So I use this word, आज कुछ green नहीं खाया मैंने. Okay. So some part of like green should be there. Proteins, of course, as per your weight, but that is not necessary because being in Marwari family, she also use this like genetically. I never had habit of eating chanas, this green teas every day, every single day. No, my body was not used to. So then I take that calculation and try to understand how your body reacts. So no matter my body weight would be 53, but even if I miss some protein part, I should break it into like 3-4 small meals and I should have that protein. It's not कि छोले बनाया तो मुझे पूरा खाना है क्योंकि मैं शाम को फिर फास्ट करने वाली हूँ तो अभी मुझे इतना प्रोटीन खाना because your body is not able to digest that food, right?
True, true.
So you
Very
should
well said.
understand. And one more thing I call, don't consider this as a dustbin. जैसे आपने कहा था कि बच जाए तो खा लेता है, better to be throw out or use something or give it to somebody, but it's not dustbin. So whatever you are eating, eat thoughtfully, eat mindfully. That is the word. So immediately few changes will be in your body, and that probably will work as a reinforcement for
Right.
you
So
to
even with
follow a
intermittent,
good diet.
sorry. So even with intermittent fasting, you would recommend that they should not start 16-hour intermittent fasting. They should probably start with 10
Yeah.
hours,
So
12
for
hours, 14 hours, and
yeah.
then 16 hours, right?
Yeah. So if somebody really want to wish to go for IF, first of all, though, we should stop eating that bite. Something is left and we are just finishing the plate, like for our kids
Munching
or for
on food.
somebody else. Munching on the food. So that like we can restrict for some days, or we can
Yes.
actually we should stop that. Okay.
Right.
And
also
second
what
thing,
I,
then like, we can
yeah.
skip some evening snacks or we can replace it with some fruits or juice. Okay, so to make you feel healthy, and then slowly within a week you will feel okay, if I'm not eating, if I'm not just passing through the kitchen or not opening the fridge frequently, I really don't have the need to eat. I am active. So sometimes
Yeah.
it's
So
just
the
our mindset.
main outcome should be that you're fasting and you're eating a good diet so that you are active, not that you are low on energy. So you should not do
Yeah.
something which will create low energy in the end of the day and you are irritable. That is not what is going
Yeah.
to be very long sustainable mode of practice. So what you have to decide is do something that is suitable to your body, and the end result may or may not be loss of weight, but you may be a healthy body, and you will be
Yeah.
still be very energetic, and you will still be very active and not irritable. Otherwise, many people who are fasting can end up being very irritable and spoil everything else around them in the, just that thing of oh, I have to have a weight loss on the weight scale. So I think
Yeah.
that should
So
not be our main
uh,
thing.
yeah, one thing just to like people should not confuse. IF has proved very good, given very good results. Okay, my point is just to adopt any lifestyle if it is sustainable. Okay, first, and second, gradually. So it should bring some positive changes in you, and if you feel my body is adapting that thing, slowly and slowly you should accept that as a
And then
lifestyle.
make that
Okay.
as your lifestyle. Make that as your
Yeah,
lifestyle.
yes.
I
And
would
certainly
also
we can cut down on this munching, no matter
right.
what. Okay, we
Yeah.
should make that our lifestyle.
Yes.
Okay.
And with this, I would also like to ask Sonia, that she comes across so many people, and there are so many women, and I'm sure all types, all different types with different issues, different problems. So Sonia, what would you say works well for most of the women? What is their understanding about fasting, or about health, about some form of exercise?
Just to share with all that, Pula, the community that I run, is a support group. And on our platform, we have different days where we talk about a lot of different topics. when a lot of women, they don't have knowledge, the first thing, and second thing, they're scared. But when they come in these support groups and they read about others stories, and when they get to know, like, okay, उसने ऐसा किया है तो मैं भी कर सकती हूँ, let me try. And that's how she gets the energy and she gets the motivation to try and become more healthy and do such stuff. And I think that is very important for women to join different support groups, be a part of it, read different posts to motivate themselves. We have such amazing experts on our group who keep writing stuff. We have such amazing members who keep sharing their stories. In fact, Manisha has also in the past shared amazing stories about her life and how she's been a runner and how she's come up from her cancer life, And similarly, like even in, like, we have a day called as Gyani Guruvar. So it's a Thursday where a lot of people share these topics. So a lot of people share about their diets, charts. In fact, a real life example, I used to weigh 110. Now I've reached 80. I've lost 27 kgs in the last around 14
Fantastic.
months. So I made the best use of lockdown because I have a very social life, and that was the reason where I could never sustain any kind of diet, any kind of gyms. I've donated money to all my trainers जहाँ मैं join करती थी, but मैं कभी कुछ sustain नहीं कर पाती थी. But because of the lockdown and I was home, I could sustain home food. I could work out. I've joined a lot of my fitness classes, and when Kritika ma'am was talking, I could feel each and every word because I have followed it personally. Your stomach is not a dustbin, as Dr. Varsha said. Keep it out, but not in. And I have followed every single thing. Protein intake, no munching, and I think that is what you have to sustainability. यानी जब तक आप खुद सीरियस नहीं होते हो इसके बारे में, it doesn't affect your body. You have to respect your body first, and it is really important for you to see the results. And now
Yeah, sure.
I love myself the way I have been. I was obese, thin, fat, whatever I am. I have loved myself and my body. I'm not talking about, I've done this for health reasons because, of course, we have to live a long life. And I've never had any kind of problems of thyroid or diabetes or anything. And it was, before I reached the age of 40, I wanted to maybe make the best use of it. And that's how, so I don't get affected by anything more. So, looking at me, I feel there are many more who I inspire. A lot of more women have started following me. They want to know what I do, how I've achieved it, and they also want to, lose weight. So it's always inspiration. कोई करता है, आप उनको देख के follow करना चाहते हो, and you want to, become healthy. So that's how it
Right,
works.
right. And what about your group of people? I think it's a wonderful platform where you inspire each other to do something good or something that you have been scared of doing. So I think platforms like Pula you have created, I really congratulate you on that, and I am sure many women have benefited from that. But at the same time, I'm not very sure whether your platform also talks about medical issues, medical health issues. Mostly women are comfortable into talking about, okay, the weight loss, the food, the other issues, or maybe some, professions. But talking about medical health, you said that Manisha had put up that story on your platform. Are there many more such stories
Yes,
that they have put and they're sharing? And
yes.
do you have a medical support group with Pula?
So just to share, we also have hashtags like share to inspire, and also we support, like, one of our motive is to break the culture of silence. We support our members. There are a lot of our members who don't have the courage to post their issues directly. So we support them in a manner where we moderators or admins or our team take the details from them and post it anonymously without the identity of who the lady is. Because क्या होता है, उनके maybe family members, friends होंगे उस group पे, and they are scared to get judged in today's world. So, we hide the identity, we put up the post for them, and to seek advice, or, if they have to seek medical advice or connections, or what is the next step, what should she do in case if she feels the main issues that are discussed medical field, it is always, gynac related, like PCOD, PCOS, thyroid, unable to conceive, um, it's been years and years that she's been trying. She's gone through different kind of methods, IVF, etc. And I think in the Indian mentality, a mother, a lady, never realizes that at a point she has to stop. Maybe she's forced to either conceive, or I don't know. Every woman has a different story. So there are many such kind of medical issues that have been addressed, but on a positive side, there are a lot of success stories. We have a lot of share to inspire stories where a lot of ladies have shared as how they have achieved good health. What do they do? How have they lost weight? Or how have they overcome PCOD, PCOS? What lifestyle have they followed? And always these support groups are like, some books, Kindle, where you're reading silently and you get inspired. So
Right.
it really helps a lot of members, and a lot of members then put up another post that, okay, like I have a lot of such posts, where in fact, just to share, there was a lady who had put up a post saying that on one of the Gyani Gurwar posts, a doctor had shared about breast cancer and how she should do self checkup, and she checked and she felt some kind of गांठ या क्या कुछ कहते हैं. So she went to a doctor, and she got to know that she has breast cancer. And she was also, of course, devastated and scared and shocked. And with the entire checkup and the diagnosis, she's overcome the cancer.
So I also understand that not all women practice self-breast examination because they think it's not important. I don't really feel anything, but here I would like to ask Dr. Sujata that you see so many young women and their mothers and menopausal women. Do you think that what do you think about that not many people follow this, and how would you encourage them, or would you be able to just tell us in brief how to do self-breast examination as a routine practice?
Yes. Self-breast examination is of utmost importance in early detection of cancer. So what my suggestion to all the ladies who are listening to this would be, do a self-breast examination on the first or the second day of your periods, at least once every 3 cycles. So in that, you might detect any changes in your nipple, any small lumps or mass. And whenever there is any such lump or any mass, any increased, any change in the texture, please visit your doctor and get yourself checked with the physical examination.
So Sujata, here I would also like to say that, all women should know that not every lump that they feel is cancerous.
Yes,
90%
absolutely.
of the time,
Yes.
those lumps will be just simple fibroadenomas or simple cysts. So, they should not be scared कि अभी lump है, so we have to go ahead and do some, if the test किया तो positive आ जाएगा. So that is also very, very important, that they should not be scared. Because whatever they feel for their hand, it is the best to just go ahead and do the examination by a doctor rather than being scared कि ये cancer होगा. हर गांठ कैंसर नहीं होती है is also a very important thing.
Yes. So the younger the age group, the chance of fibroadenoma is very high.
Sorry. Yeah, go ahead.
Yeah. So younger the age group, the chance of fibroadenomas is very high, and it is very commonly seen in these days. Anupama ma'am will also enlighten us about it. But so this fibroadenomas also, they might grow. So just for a routine checkup or an examination, definitely, if there is any lump, as even Manisha has said, she found a lump, and then because of the self-breast examination.
Yes, it was detected at a much earlier stage.
Yes.
Here I would like to ask that, though we say that, okay, only when you feel the lump you come ahead for an examination, I don't think that holds true, because we are not aiming at detecting lesions or diseases when they are clinically palpable or clinically evident. So what should the women generally follow for their health? So as to, if at all there is a problem, it is detected before it is clinically manifested.
This question for me.
To Anupama.
Yeah, okay. So basically what we are talking about here is screening. So screening is actually detecting a disease before it manifests as clinical symptoms. So there are 3 ways actually how you can screen for breast cancer. One is, of course, breast self-examination that we just talked about. That means that the lady herself checks her own breasts for any lumps or any changes or nipple discharge or whatever. This is a very simple method, and every lady can do it at home on the second or third day of their menstrual cycle when the breasts are very soft. It is important not to do it before the menstrual cycle, because at that time the breasts are engorged, they are congested, they might feel lumpy, so you might actually miss a correct breast lump. So please do the examination on the second or third day of your menstrual cycle. The congestion reduces, and then it's easy to pick up any new lump. And follow this every month. If not every month, at least once in 2 to 3 months. Keep doing that. And the second way to screen for breast cancer is known as clinical breast examination. In fact, Tata Memorial Hospital has recently conducted a very big study on clinical breast examination, how it reduces mortality from breast cancer by almost 30%. So just imagine how useful this technique is. So clinical breast examination means that you go to a doctor every year and let the doctor examine your breast. The same thing that you're doing at home in your self-examination, the doctor will do in the clinic, but because they are trained for it, the health workers are trained to pick up any breast changes which you yourself might not feel. So they will be able to pick up any breast cancers very early for you. So annual examination with the doctor, a clinical checkup is important. And then the third thing also which is important is the mammography. Mammography is a special X-ray of the breast, and mammography is advised for all women above 50 years of age, definitely once every 2 years till the age of 70. And this can pick up any lumps before they even become palpable. Palpable means before you can yourself feel the lump, before it becomes big enough. Even very small 2-3 millimeters or 4 millimeter cancers can be picked up in the mammograms. So one mammography every 2 years after the age of 50 is a must till the age of 70. However, because in India we get a lot of breast cancers in younger women, so we must start screening even younger than 50. So 40 to 50, this age group also must start checking very rigorously. And for them, breast self-examination, clinical breast examination, and mammography. We would recommend mammography even for women from 40 to 50 years of age group. But in scientific circles, the 40 to 50 years of age group screening by mammography is a little controversial. So you may or may not do it, but it is advisable to do it.
Two schools of thought on that, because some countries like USA probably start the thing at 50, but the other countries also start at the age of 40. And then, it's a lot of debate about that. But in our country, we do recommend that from the age of 40, they can start doing a screening mammography. Now, having said about all these things about, the breast health, the gynecological health, how to do self-breast examination, how to do mammography. Unfortunately, even then, suppose you probably have breast cancer detected. What I want to emphasize here is that the body of a woman, mentally as well as physically, has to be very fit and strong. Only then she will be able to overcome and sustain all the negative things that will go along with the breast cancer diagnosis and treatment, because it is a long treatment. You have radiation, you have chemotherapy, and for that, I think, or for any other disease, let's not talk only about breast cancer, it could be simple backache kind of thing, or a simple knee problems, or whatever it is. It is very important for women to have a very healthy mind as well as body. And I think we should work towards it at whatever age we are. We are at 25, we are at 40, we are at 60. We have to start doing that our minds have to be calm, our minds have to be positive. There has to be no negativity, there has to be good karma, there has to be good health. And I think Dr. Manisha will be able to highlight the advantage of having a very good nutrition, very good body, very good fit body, to overcome all these small troubles and aches and pains and the treatment related problems that otherwise can be faced by women, which will put her more down. But if it is not that way, if she has a strong positive mind, if she has a strong physical body, she'll be able to sustain through that and be victorious and we come out as normal, as is an example that we have from Dr. Manisha. So Manisha, I would like you to say certain few things about that on that note.
Yeah, so you're absolutely right there, Varsha. A lot of the component of our illnesses there is a mental component also which is involved in this. And to overcome, not just, so cancer is just one example. Any disease has a mental component as well. So I also did a lot of I did a lot of emotional healing sessions as well to help me to deal better with my diagnosis. I feel that there is a lot of emotional component that goes into development of a disease. So therefore, Krutika always, she will agree with me on this, that doing meditation, calming your mind, this is something that so as you've rightly said, Varsha, I've been a motivational speaker and a corporate speaker also for quite some time. I've been invited to give talks in a lot of women's forums, and one
So
of the things
I
that
just want to understand one thing. When you're
yeah,
saying emotional healing,
yes.
what do you mean by that?
So there are a lot of, so with women, typically what happens is that there are a lot of repressed emotions that we have, which we are most of the time incapable of expressing. It is our patriarchal society which we deal with. It's going to be a long time before that changes. And that is one of the primary reasons that I believe is where the disease process actually starts from. And so I went through a lot of emotional healing therapy sessions. I did a lot of self work. See, there's a very important sentence that I will say, which was taught to me at that time and which I practice on a regular basis. So situations don't change, people don't change. But what changes is your reaction to them, is what you can change. And once that reaction that you give changes towards a particular situation, towards a particular person, then automatically you start seeing that probably that person also seems different, that situation also seems different. And now this is something that I learned at that time. And I practice it even to today. So there,
And
I
you
feel,
practice it in all
yeah,
aspects. It's not just related to
yes,
your health.
yes,
It's actually a very good practice, a very well said
yes,
thing that
yes.
nothing is going to be around you. It's your attitude or your reactions that should change,
You can
which you
change,
have to calm
yes.
down.
And that was very helpful. So when I give these talks in these women's forums, what I always tell women is it so hard for you to take out 45 minutes to 1 hour, 60 minutes of time on a daily basis to work on your own health? Is it so hard? So I see women, I live in a housing society, and I see women come out every evening, chatting, gossiping with their friends in the
Gossiping.
evening. But instead of sitting in one place and doing it, yeah, I mean, we are women. Whom are we kidding? We love
Love
gossip.
gossip.
But anyway, the point is,
We thrive.
so instead of sitting in one place, is it so hard for you to just walk with your friend while you're chatting, moving your arms around, and just making your body work for you? So I always say this in all the forums where I go as a speaker, that is it so hard for you to just take 30 to 60 minutes out of your day and devote it towards, now you take your children to the playground, isn't it, when you have small children? So is it so hard when your child is on the swing? Why can't you just take a few rounds in that garden? Catch a friend, do your gossip, it's okay, but at least you'll be working on your body while you do that, and your child is playing anyway, so you achieve what you
So
want
you
to do.
suggest that every day take just 60 minutes out, focus
Yes,
on your mind and your
yes,
body,
yes,
improve day by day. There's not going to be sudden changes or classic changes within a month or so, but it will become your lifestyle, and then
yes,
probably you won't realize after 2 years you have changed in so many aspects and they are good for yourself.
correct.
So that is also very well said. Now we are coming to a little end of our discussion. So I'm going to tell each and every speaker to come up with like a two-liner message for all my audience. And in the meanwhile, I'm going to request Kritika to show very simple daily 5 yogasans, or whatever is possible very easily for all our audiences, and which are going to benefit. And then I'll come back to each one of you to give your 2-liner messages to the audience before we conclude. So on to you, Kritika. Would you be kind
Okay.
enough to show us few simple examples which
Yes, yes,
have
yes.
made you so fit and energetic?
Definitely. So now my interesting part comes here. First of all, like Manisha told that if you are in the garden, you can walk. Okay. Suppose few ladies will say we don't even get time to go to the garden every day. Okay. Then what? If you are going out, of course you should walk. You should move your arms. But if you are at home or if you are in the office and if you cannot do anything, really that day is very hectic day for you, there would be 4 to 5 things which will make you feel energetic or fresh, even if after the hectic schedule. So first thing is, of course, sitting in the Vajrasana. But again, Vajrasana needs some practice. Not all ladies or all women or people can sit. So you can have some pillow. If you are in the office, you can have some sadar, something like that. And first of all, is start practicing sitting in Vajrasana. This is the one thing which makes your spine erect. Second thing, it is good for digestion because your digestive system really gets activate here with this posture. We'll not get into detail, right? So simple asana, Vajrasana. On your knees, join your big toe and start sitting. Now, suppose my body is reacting in a different way, start with a single second. And definitely in a month, I'm talking about the person who really
Extreme
cannot
case.
sit in Vajrasana, extreme cases, then in a month they will be able to sit with some handkerchief, some support under their ankle. One thing. Now, this asana you can make it as a stress free. So you are in office, you have a long chat, discussions, some annoying arguments. Yes. So then, if you know how I can sit in Vajrasana or in a chair I have sat, what should I do? Forward bending. That is something we don't do in a daily, day-to-day basis. We can stand, we can sit, or we can slip. And there is no exercise. I'm talking about no exercise zone, right? So you can do forward bending. You are sitting either in a chair, inhale both hands up. So see, here again your body posture helps you to keep your back, your spine upright. Keep looking straight. This is the uh, secret term. When you keep looking straight, you are bending through your hip, not through your back. Many a time we do this, so you will feel a hunch, right? So this is not the way. Inhale and exhale. Move your neck slightly towards from the left to right, left to right. Be there slightly. Feel your toes, feel your touch to the toes with your palms. And third asana is twisting that we normally do not do when we are not exercising that day. So right to the left, so it's a twisting. Okay, one. And second twist is you hold the chair, arm of the chair, the other hand, the other palm is completely at the back side. You can keep at the tailbone and start moving your shoulder to the left. Okay, if you have hold the armchair to the left side, then to the left and slowly, slowly. So hold it for 30 counts to 1 minute gradually. Keep on breathing. It will help you two ways. One, you understand your breath. So we had started conversation with this. You become conscious. And second, the twist help you to slightly improve the posture of spine, or it stimulates, whether I would use the word. Okay, and it helps to increase the efficiency of your pancreas or some of the digestive organs by this twisting and turning. So forward bending, twisting, sitting in Vajrasana. These are very simple asanas, and you can do it anywhere where you are, or working or at your home.
You don't
right?
need anything. You just need to your mind
Other
for
two
that.
Yes. Other two, shall I show now or?
Yes. No, now only.
Yeah. Yeah. Now again, many people do complain that I had very bad hectic day. But again, two things we miss on a regular basis is backward bending. We can stand, we can do forward bending, getting the things right. Again, the alignment and posture work, that is a different separate topic. But work on your alignment, work on your posture. If you are really doing forward bending, you see to it you are not hurting your back so often. And backward bending is one thing. If you are having that fear or phobia, then you may not start with the standing backward bending posture. The right way is this, of course, in a long run, you push your back, you start pushing your back, you make your shoulders drop, you make your neck drop, drop till the point you feel comfortable and keep on breathing. Now, again, when you want to come up, you are making your back straight, your shoulders straight, and your neck finally. Okay, so this is the posture where I feel, see, many of the time we do Surya Namaskar, we do something, but backward bending is something we really miss on. So we don't develop that flexibility, that stimulation on an everyday basis, right? And fifth thing is we don't heal our legs many times, even if sitting in the sitting posture. Of course, they do get some pain, right? They get numb or we feel stiffness. So one of the important posture, so suppose you are in Vajrasana, you are doing backward bending, you are twisting, turning your body, and then this is spine stretching. Okay, so actually you are making your body completely relaxed. Now, what if I am stiff body? That's perfectly fine. Take n number of props, or at least your hands. You are in office and start sitting like this, and slowly, 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 slowly. Where you get the timer? Somebody will tell me office में ये कौन करता है? Okay, if you have that space, if you can do it, then slowly, slowly, slowly you start coming down. Okay, with daily practice, and stretch your arms, head down, slightly pulse towards the left and right. It actually helps you to uh, supply the more oxygenated blood from your heart. We all know that our process is like heart is here, right? If you really want to give a good supply of oxygenated blood, what we should do immediately either do forward bending or spine stretching, and you get that energy immediately within 30 seconds, 1 minute. You start feeling fresh. You can answer. You are not getting irritated. So
Yeah,
this is something you can do it, right? It's doable. It's
very much
really
doable.
doable. And
Very much doable.
I call this I call this magical fingers. I have got a new term. So suppose there is some ache, you are sitting in the office, you can always take your hands back, and this fingers only help you to relieve the stress, okay, of your own body. If it is too mild, I'm not stopping the job of physiotherapist or or trying to tell you to become physiotherapist, but yeah, yeah. So this is the magical fingers. Keep on moving, wrist, fingers, opening, gripping, okay, slightly doing stretching, and actually you can use this, okay, to massage your body whenever you get time. This is something newly I have found, and I'm loving it.
Oh,
Okay.
great.
Along
Great.
with this, many people know sun salutation, so this is not the all. इतना करने से तो सचमुच ज्यादा फर्क नहीं पड़ेगा. It's
और ये तो
something
शुरुआत है. You
which
can
keeps you
start this, and then you
शुरुआत.
can.
But this is, yeah, but जैसे सूर्य नमस्कार है और basic awakening है. I call it daily awakening of your muscles. तो पूछना है मुझे कि क्या मैंने अपनी neck को awaken किया, shoulders को awaken किया. So do 2 to 3 asanas of strengthening your that specific part of the body, and 3 to 4 asanas of flexibility or muscle toning, body toning. Okay, and then you can probably sit in meditation. Meditation is nothing. This is understanding your breath, and physical asanas will help you to focus on your very important reality, that is breast. Okay, so that is connected, really connected, connecting the dots. Okay,
Connecting the
so this is
dots.
what I feel.
So
Yeah.
there is so much that we can discuss, and we have such prolific speakers and very inspirational panel here. But I'm so sorry we have less time, and we really cannot cover everything in one day. So we'll leave certain things for the next time. But I'm very happy to have all of you here and share your thoughts. And I think it's a start, and we can keep doing this more often as and when we get the opportunity. And probably I need to have only one speaker at one time giving the entire then only it will make some it will be helpful, and also there'll be justice to that person. But unfortunately, because of time, and I'm information, lot of carry home messages, and I think nothing better than doing it around Women's Day. So I'm coming back to each one of you. I want just 2 line messages to all my audience, and thank you so very much to be with me today here on this platform. So first, I'm going to come to Dr. Anupama.
Yeah, so I would like to say to all the ladies over here, please focus on your wellness. Wellness is actually absence of disease. So prevent diseases, focus on wellness, and you will never develop diseases.
Thank you, Anupama. Very well said. So my next one, I'm coming to Dr. Sujata. Sujata, we can't hear you. I think, Sujata, we can't still hear you.
Ma'am, am I audible now?
Now you're audible.
Yeah. I would like to say Happy Women's Day to all. All the women, please don't fear cancer. Do self-breast examinations and visit your doctor at least once a year for your health checkups, or earlier if any symptoms. And just remember that you are the most important pillar of your family. So please take care of your health in all the aspects. Thank you.
Thank you, Sujata. Thank you so much for being here with us today.
Thank you.
Moving on to Sonia, can you please give a message to our audience?
Thank you so much for having me on the panel and wishing everyone a happy Women's Day. My message to everyone who's listening to us would be stop looking for tips to look beautiful, but start looking as how to be happy, because that's what is going to make you beautiful from inside and last longer.
Very well said. Thank you so much, Sonia. So coming to Kritika. Kritika, what do you have to say?
So I call it's a looking glass self. You look in the mirror and you strive everything, you do everything what you want to become. Okay. If you don't like yourself, you will not be able to like others. So love yourself, focus on yourself, on your breath. That is the important reality. And when you want to look beautiful, beautiful is a state of mind, not a state of body. That's what I want to say.
Thank you. Thank you so much, Kritika, for being with us here today. And coming to Dr. Manisha.
You.
So
Dr.
my
Manisha,
message to all the beautiful women out there is a fit woman inspires a fit family. So work towards your fit every single day. And thank you very much, Varsha. Thanks, Anupama, for having me on this panel. It was really nice to listen to so many inspiring women. I'm really grateful to you all. Thank you and happy Women's Day to everybody.
Thank you, Manisha. Thank you for being with us. And with this, I think I will conclude, and my message to all my audience would be the most important thing what I consider is being happy. And being happy is a state of mind, whether you are obese, whether you are thin, whether you're tall, you're small, it doesn't matter. It's a state of mind. If you are happy, everything will be in place. And I think that will help us creating good next generation, because they look upon us as role models, and our message to them should be nothing else matters except for being happy in life with whatever we are and whatever we have. So that is my message to everybody, and wishing everyone a very happy Women's Day. Be strong, be happy. Thank you very much.
Thank
Bye,
you.
everybody.
Thank you so much. Thank you so much.
Thank you. Thank you.
Bye. Bye.
Varsha, I guess. Thank you, Dr. Anupama.